Let's start. Okay. Good morning, everyone. We'll go ahead and get started. So we make sure that we have all the time that we need for all the exciting speakers that we're going to have. I am Marina Reutman. I'm from UCSF Fresno, and I am honored to be the current NCSCG president. Without further ado, welcome to the 21st annual GI Symposium put up by NCSCG. This is amazing that this has been going on for over 2 decades. I'm proud to be involved with the society for the last 7 years, and this has been super exciting. Today, I am excited to say that we have 175 people registered for this conference. And I'm also told that we have a few walk-ins, so we're probably going to exceed that number. This is the highest number that we've ever had. So we appreciate each and every one of you for that. Thank you. Let's see. Well, it is the program overview is it's a joint partnership between Medical Education Resources and Northern California Society for Clinical Gastroenterology. And it is our 21st time doing this. We are looking forward to educating gastroenterologists, internal medicine providers, family medicine providers, nurse practitioners, physician assistants, and nurses. Again, thank you for all of you who came to listen to us. I am very excited to introduce our planning committee. They have done a remarkable job and spent many, many evenings planning this exciting activity. Michael Alper, Christina Chow, Lawrence Leung, Neil Stolman, and Robert Wong. A round of applause for our planning committee. There's planning committee disclosures. Moving on to our faculty. Again, my sincere thank you to all the faculty to made their time to be here with us and to educate us. And you will hear about each one of them and from one of them over the last 2 days. Thank you again for coming. Disclosure of relevant financial relationships. This is a very, very long slide. All it means to say that the planning committee and the CME committee has done their job to make sure that we provide you with unbiased, scientifically vetted information. Educational objectives. We are looking forward to describing current guidelines for treatment and management of patients with chronic liver disease and GI disorders. You will be able to employ an evidence-based approach to patients with chronic liver disease and GI disorders. And at the end of the day, we will all be able to optimize treatment results for patients with liver disease as well as GI disorders, utilizing new and exciting therapies. Accreditation, we are CME accredited for 6.25 credits. Of course, claim only those that you've attended to. We are also accredited for 6.25 MOC credits. And for those of you who are physicians, know that the MOC credits are very valuable. So make sure you claim them. And this is how to claim them. So there's a number of ways to do it. You've all received an email with the link. You can do that. You can go ahead and scan this QR code, and this will take you to the registration page for pre-test. And this is the same page that's going to be there for claiming your CME credits. So please make sure to complete the pre-test before 10:40 a.m. This is very important. I have done this yesterday. There's really exciting and fun questions, and I'm looking forward to learning which ones I got wrong. So this is how to do it. And I know it looks intimidating on the slide, but I promise this is just a few clicks away. So first you are going to select register or take the course button, and you are going to register for it. If you've been here before, you can just click the take the course button. And if you need to create a new profile, please do so. For those who you've been before, it's already there for you like it was for me. It was super easy. And so complete the pre-test, and at the end of it, please complete program evaluations. And this is also where you're going to go to claim your CME and MLC credits. If you're having technical difficulties, please see one of the staff or any one of us. We would be happy to help you with that. And we are very grateful to Salix Pharmaceutical for an educational grant to support our activities. A round of applause for Salix. Thank you. And without further ado, we're going to roll right into our program. And it is my pleasure to introduce Dr. Kian Keyashian. He's a clinical associate professor of medicine, gastroenterology, and hepatology at Stanford. And without further ado, again, the management of inflammatory bowel disease continues to evolve with the introduction of biologic and small molecule therapies with the goals of emphasis of healing the bowel. Dr. Keyashian's career goal since graduation from the IBD Fellowship in 2012 has been to improve the outcomes and the quality of life of patients with inflammatory bowel disease. In line with these goals, his research focused on investigating new non-invasive diagnostic tests, finding factors early in disease course that might predict a more severe course of the disease and need for different therapies, as well as investigating new promising effective medications with fewer side effects. Please welcome Dr. Keyashian.
Okay, you guys can hear me. Great. Well, first of all, I want to thank Marina and the conference organizers for allowing me to speak at this conference. What a great conference you guys have put together. This looks amazing. The agenda looks great. And so we'll have a good couple of days together. Am I going the right way here? Let's see. There we go. So I have no disclosures. So we got a lot to cover in 20 minutes here. We're going to talk about diagnostics. We're going to focus on intestinal ultrasound and where that's going to fit in our practice. We're going to look at predicting disease course, particularly in Crohn's disease. We'll look at some treatments, particularly with a focus on treatments from DDW, looking at new and upcoming therapies, special populations, including perianal Crohn's disease and ileopathitis. And then we'll finish off looking at new vaccination approaches, mental health impact. So we got a lot to cover, but we'll get going. So first, to talk about intestinal ultrasound. There are a number of shortcomings with the current diagnostics in IBD, and I've listed those there for you, but we're all well aware of those. Bowel ultrasound is quick, portable, can be done at the point of care of seeing the patient, requires no radiation, no IV, it's a short exam, doesn't require bowel preparation, has minimal risk. And it can be used in diagnosis, monitoring response and relapse, detecting complications. And the standard for assessing inflammation largely focus on the thickness of the colon. So you've got the image on the right, but a colon diameter, wall diameter greater than 3 millimeters, or an ileal diameter greater than 2 millimeters tends to be the standard. I put this on your radar because you're going to see this as endpoint in clinical trials. They've done patient surveys that suggest that ultrasound is preferred over other imaging modalities. So this really is going to be a way of the near future. And so that's one important diagnostic to be aware of. The other area that's difficult in monitoring is understanding what to do with the patient with mild Crohn's disease, small bowel Crohn's disease, colonic Crohn's disease, not much symptoms, and how to plot out their course without really knowing what the future holds for them. And so there are numerous phenotypes and complications of Crohn's, and predicting aggressive disease early is helpful to decide, do I want to get aggressive with therapy? Do we want to monitor? These are some of the important pieces. And so starting in 2016, Corey Siegel put together a web-based tool to individualize risk in Crohn's disease, and this is the PROSPECT study. You can see that this looked at patient characteristics, disease locations, serologies, and genetics, and gives a profile like the image in the middle, low risk, medium risk, high risk. More recently, they've actually validated this. And so you can see in a calibration cohort and a validation cohort that what you're characterized really translates to risk. So the black bars are risk, and you can see that the highest risk group, by this characterization, does end up with more complications over 3 years. So there may be some benefit. This is currently called CD path, but it might be worthwhile to think about this in our patients with mild Crohn's disease. So then we'll talk about therapeutics, new ones. So risankizumab, we know that's not new anymore. That was FDA approved in June of 2022 for Crohn's disease. What is relatively new is the comparison to ustekinumab in a study called SEQUENCE, a phase 3b study that looked at important outcomes at 24 weeks and 48 weeks and found some significant improvement better with risankizumab in clinical non-inferiority at 24 weeks and endoscopic response at 48 weeks. So helps us in placement. Vedolizumab sub-Q given as 2 initial infusions followed by 108 milligrams every 2 weeks is now approved. The adalimumab biosimilars, a number of us are probably familiar with these as companies are asking us to switch, and some of those are interchangeable. I'll focus on upcoming therapy, particularly with some of the IL-23 blockade. We'll talk about mirikizumab. Guselkumab is another one. We'll talk about selective JAK1. Another one to note is selective JAK1 inhibition with filgotinib. S1Ps, ozanimod seems to be moving forward. And then combination guselkumab and golimumab. Combination therapy seems to be moving forward. So we'll talk about mirikizumab. So we already talked about the SEQUENCE study that suggested that risankizumab may be placed before ustekinumab in some selective patients, but it's unclear whether mirikizumab has a role. And so this is where we look at the VIVID-1 study. This was the study that led to the approval of mirikizumab and looked at endoscopic response and clinical remission. And here the data looks a little bit different than SEQUENCE. Now we have to take this with a grain of salt. There were some significant differences between VIVID-1 and SEQUENCE. But in this study, which was a secondary endpoint where you compared mirikizumab to ustekinumab, we can see that certainly mirikizumab does better than placebo, but in comparison to ustekinumab, we're not finding significant improvement. Now, there are some caveats here. If you look at some of the secondary endpoints like histology or a combination of clinical and endoscopic response, you may find some benefit at 52 weeks, but not as robust. And I encourage you to read a little bit about the differences between the VIVID-1 design and SEQUENCE. But this was something that was a DDW that garnered a lot of attention, comparing these IL-23s to IL-12/23s. Moving on to ulcerative colitis. What's new is mirikizumab, FDA approved, etrasimod, sub-Q vedolizumab, the adalimumab biosimilars, and then an increasing role for JAK inhibitors for our hospitalized UC patients. We're going to focus on that. The other areas we're going to talk about briefly are upcoming therapies. So we'll talk about risankizumab and ulcerative colitis, guselkumab, another IL-23 blockade, filgotinib, selective JAK1 inhibitor. I'm just putting things out there that you will probably see here in the next 12 to 18 months. It's showing up as moving along in our approval. We'll talk a little bit about this new agent with a new mechanism, a microRNA, obefazimod, a mechanism of TL1A1 blockade, which helps with fibrosis and inflammation, and then combination therapy is being looked at as well. So we'll look at a few of these things. Let's first look at our inpatient UC population. So TRIUMPH is the study I want to highlight from DDW. We know there's limited data on JAK inhibitors in acute severe UC or inpatients. So TRIUMPH was a phase 4 observational study that was conducted in Canada, where patients who, about a third of whom were TNF experienced and had failed 3 days of IV steroids, were given tofacitinib, 10 milligrams twice a day, and they assessed clinical response at day 7. And this was an interim analysis. They don't have all their population together yet, but they presented this at DDW. So what did we find? We found that about 60% of patients responded to tofacitinib, 60%. It's a pretty good statistic there, and typically with a mean number of days of about 2.5. If by day 5 they had not responded, they probably were not going to respond. And as you can see on the figure on the right, if the CRP started to reduce by day 2, you were more likely to be a responder. So this is encouraging, and it suggests that there is a role for tofacitinib, particularly in our TNF experienced patients for inpatient UC. Of course, the main medication that's been used in inpatient UC is infliximab. And at Stanford, we have this debate, including with our pharmacy team, of what is the optimal dosing strategy for infliximab. Because it's not exactly clear. Do we give 5 mg per kg? Do we give 10 mg per kg? If they're not responding after 7 days, do we give an additional 5 mg per kg or 10 mg per kg? And so I present the PREDICT-UC study, which was an open label randomized control trial from Australia, where they did just that. They compared 10 milligrams per kilogram versus 5 milligrams per kilogram, an intensified regimen. And they looked at day 7 clinical response. And so this was a good number of patients. They also looked at outcomes out to 3 months, including colectomy, steroid-free remission. So the primary outcome here was surprisingly not that impressive. So 10 mg per kg versus 5 mg per kg did not result in increased day 7 clinical response. And that's also true at 3 months. It didn't have a difference in terms of colectomy, in terms of steroid-free remission, in terms of success, I would say. Now, the one area where we learned a bit more is that we found some predictors. So in the 5 mg per kg group, if the albumin was low, they were less likely to respond to 5 milligrams per kilogram. And that's also true of those patients that had higher CRP or higher Mayo endoscopic scores. So I would say what we learned from PREDICT-UC is that, yes, just off the bat, everyone should not get 10 milligrams per kilogram or need an intensified accelerated regimen. But I would say that for select patients, low albumin, high CRP, pretty severe inflammation on colonoscopy, you may want to think about 10 milligrams per kilogram. That was helpful. We talked a little bit about risankizumab for ulcerative colitis, and this got some press at DDW. Not yet approved for ulcerative colitis, but certainly moving in that direction. And so remember that the INSPIRE studies were the induction studies. And so I present here the results of COMMAND, which was those who had responded getting re-randomized to either withdrawal of therapy or continuation. And they looked at clinical remission at week 52 in a good number of patients. I've got a busy table for you here, but let me tell you the take home. The take home is that it performed both at the 180 and the 360 dose. It performed better than placebo in almost all outcomes, including patient-reported outcomes of bowel urgency, abdominal pain. What's interesting and not surprising is that those, if you look at the overall population divided into immunosuppressive history, anti-TNF history, you found less response in those that have been exposed to TNF inhibitors and other biologics. And so that's not too far off from what we would expect, but it seems to be moving forward for ulcerative colitis in approval. I'm a big fan of new mechanisms, particularly for Crohn's disease, where we really, for these refractory patients, need some new mechanisms. And so I want to highlight an earlier phase study, obefazimod for ulcerative colitis. So despite the mod ending, this is not an S1P modulator. In fact, it's a microRNA. It increases the expression of microRNA. And so you reduce the downstream expression of inflammatory biomarkers. It's an oral, 50 milligrams once a day. And it's looked pretty good. It's moving forward in phase 3 in ulcerative colitis. This was a study to look at what happens to patients who respond. So about 60% of patients, they give this oral as an open label, and they respond. And then what happens to those folks at 48 weeks and 98 weeks? And you can see here that it seems to have some promise. About 60% of patients who respond by week 8 maintain 60 to 65% maintain clinical response. And so I think this really is something to put on our radars as something that's moving forward. It's certainly further back than things like risankizumab, but certainly way of the future. Hopefully it'll pan out in phase 3. We'll see. And then for the last piece of treatment, I want to talk about 2 groups that have received less attention: perianal Crohn's disease and ileal pouchitis. And there were some good recent studies. So I want to talk a little bit about mesenchymal stem cells for perianal Crohn's disease. We know that combined surgical drainage and anti-TNF use results in closure of about 50 to 70% of fistula, perianal fistula. Less evidence on ustekinumab, maybe more so than vedolizumab, but both data is pretty limited. We know that 20 to 25% of our patients with perianal Crohn's have refractory disease. And so mesenchymal stem cells, which are allogeneic adipose-derived stem cells that are injected locally in tracts after a clean out, appear to have some benefit. They're easy to collect with abdominal liposuction. They have long-lasting benefit, and it's approved by the European Medical Agency. And there are multiple phase 1, phase 2, phase 3 studies like ADMIRE-CD, which was an Israeli and European study that really showed benefit over placebo in combined remission and efficacy. So I do think for our patients who have gone through the TNF gamut, who will hopefully get more evidence on these more advanced therapies, but are still refractory, I do think mesenchymal stem cells may be an opportunity in the near future. The other area that I'm excited about is pouchitis. This is an area that's largely lacked literature. It's largely based on case series. And so we have a tough time when an insurance says, why are you prescribing vedolizumab or tofacitinib? We don't have a lot to come back with. And so we know chronic pouchitis occurs in about 20% of patients after total proctocolectomy and ileopouch anastomosis. The EARNEST trial, which was published in 2023 in the New England Journal, is the first randomized controlled trial looking at vedolizumab in chronic pouchitis. This was a multi-site study that looked at remission as defined by the Pouch Disease Activity Index. And this study was encouraging, looking at week 14, which was their primary endpoint, but also week 34, we can see some differences versus placebo in terms of percentage of patients that achieve remission. So the EARNEST study could be something that we have if we want to use vedolizumab for our patients with pouchitis who are not responding. The other area that got press at DDW in terms of chronic pouchitis were JAK inhibitors. So here's a nice study that Ku presented at DDW, which was an open label induction and then a randomized withdrawal. So patients who are not responding to conventional therapy get tofacitinib 10 milligrams BID, and then after 8 weeks, they are either withdrawn or continue therapy to see how they do. And this is the data that they presented just up to 8 weeks. And so we don't have a randomized arm yet. That's coming. But it's a nice study to look at what happens in this group from baseline to week 8. And so you can see in all of those pouch disease activity indices, there's improvement from baseline, with improvement also in quality of life as dictated by the SI-BDQ. And so I think to me, certainly we don't have the randomized data yet to talk about tofacitinib or other JAK inhibitors in pouch disease. Vedolizumab is the only one that's done that thus far, but we will have some exciting data, hopefully, from this that allows us to have one more tool in our patients with refractory pouchitis. So that's our treatments that I wanted to highlight. And then for the last part, we'll talk a little bit about a couple of interesting studies looking at health maintenance. We're going to talk about vaccination strategy, and then we're going to talk about the effect of mental health on disease flares. So we know that patients with TNF inhibitors, possibly other advanced therapies, do have a suboptimal response to vaccines. And the optimal vaccination schedule, for example, for pneumococcus is unknown in those on this therapy. And so this prospective randomized control trial, which was a multi-center study, looked at an intensified regimen of vaccination in patients who were 5 years out from their initial vaccination. They got an additional dose of Prevnar versus the normal strategy. And they looked at protection. And I'm not going to get into details of that, but there was a couple of rigorous metrics that they used to confirm that there was increased protection for these patients. And what I would tell you, and again, this is sort of the population, 88% on TNF inhibitors, 12% on vedolizumab. And at month 5, and really out to month 36, there were significant differences in response with this vaccination strategy. So I do think that in my mind, this is sort of one of the first studies that looks at how to deal with this issue of reduced response to vaccinations. And I encourage you to read more about this study, and the source is there for you. The last topic is something that a lot of patients talk to us about, right? And that's mental health and whether that impacts flares. Patients have been convinced for a long time that in periods of stress, they do flare. And we've been sort of, because the evidence has been weak, we've sort of said, certainly symptoms can get worse in times of flare, but we haven't found good evidence to suggest that inflammatory markers increase and we have a true inflammatory flare. I refer you to this 2023 study, which was an interesting study on 110 ulcerative colitis subjects in clinical remission who gauged their stress over the next 65 weeks. And there was a rigorous following of the colitis activity index every 2 weeks, calprotectin if that index reached a threshold of 5. And here's what's interesting. So in patients who perceive lower stress, you can see less clinical flares and less biochemical flares. But in patients who had high perceived stress based on surveys, there was a significantly higher risk of clinical flares. There was a trend towards biochemical flares, but I do think that this study warrants some attention to suggest that, perhaps flares are important. Now, what to do about that is a whole different story, but at least it's a helpful confirmation of what our patients have been telling us for some time. So I know that was a gamut of things that we ran through. And again, the studies are all there for you to review, but I just wanted to highlight some of the upcoming therapies. Let's review that if we can. So we talked about diagnostics, we talked about treatments, we talked about health maintenance. So we know that point of care intestinal ultrasound is coming for diagnosis and monitoring, and we'll spend maybe a little bit of time on the Q&A if you guys are interested in talking about that. It's going to be a clinical trial endpoint, and patients prefer it. We know that we've got some web-based tools that we can now use to predict the course of mild Crohn's disease, one of the toughest patient populations to manage in terms of decision-making. In terms of treatment, mirikizumab may be preferred over ustekinumab in Crohn's disease, but we didn't get as robust a data. But again, some population differences compared between VIVID-1 and Sequence. In inpatient UC, JAK inhibition and dose-intensified infliximab may have a role. But again, remember the 10 mg per kg would be if there's low albumin, high CRP. Risankizumab, more so than obefazimod, are moving closer to approval. Mesenchymal stem cells can be used in Crohn's disease, and vedolizumab and tofacitinib may have a role in chronic pouchitis. And then health maintenance, we talked about an intensified vaccination regimen, which may be helpful, and started to see that maybe stress can play a role in the flare of ulcerative colitis. So that was that. Great. Thanks.
So I've known a woman at Stanford named Linda Wynn for a very long time. I knew her at CPM. I knew her when she was a fellow, actually. I was helping with her life then. And she grew up and became this, superstar in neurogastroenterology. And she moved to Stanford. And she's really my lifeline. And I have so many patients that I need her help with. And then, I don't know, 3 years ago or something, I can tell you exactly when, she said, yeah, well, I'm not taking over that anymore. I got this new person who's coming in. And I cried, I think, that I was going to lose her. And I needn't have cried, because her replacement as director of neurogastroenterology at Stanford is, of course, our next speaker, who is Layla Nashadian, and she is as good or better and spectacular at that. She runs the Neurogastro Center. She runs the pelvic, what do we call it? A pelvic health center. She runs their fellowship, their motility neurogastroenterology fellowship. She's got a lot of titles. She's a super smart person, and she's going to teach us today about a practical approach to chronic constipation and pelvic floor disorders. Dr. Nashadian, thank you.
Thank you. And thank you to the organizers for inviting me and Dr. Sulman for the kind introduction. Of course, I've never been claimed to be like Linda, but that's very nice of you. So I guess the green button. Okay. Oh, okay. I'm sorry. So disclosures and why do we need to talk about constipation? This is the most common DGBI disorder, disorders of the gut-brain interaction by the Rome Global Study, and the prevalence of constipation in North America is somewhere around 10%. And that's why it's really important to know the symptoms of constipation and what do you have in your toolbox to address the patients who come with these complaints. And that's going to be the topic today. So let's talk about the symptoms of constipation. Any patient who is coming to you with infrequent bowel movements or hard and bumpy stools, or the patients who are complaining about the straining, the need for digitation, the sensation of incomplete evacuation. So many of these patients may have frequent bowel movements, but they are small. They need to strain and they are not feeling completely done after each bowel movement. If these symptoms are persistent, more than 2 of them in over 25% of the bowel movements, these patients have chronic constipation. If there is a component of abdominal pain that is predominant in these patients, in the setting of the constipation, these patients are diagnosed with the irritable bowel syndrome with constipation predominant. subtype. And if these symptoms are in the setting of the opioids, opioid-induced constipation is the diagnosis. For functional defecatory disorders, these symptoms are not any different from the patients with IBS-C or patients with chronic idiopathic constipation, but these are the patients who have the same symptoms. For the diagnosis, you need to do anorectal physiologic testing here. And finally, the newer diagnosis is the occasional constipation that came through the ROM4, and you will hear more about that. This is to be very conclusive of all patients with constipation. These patients may have erratic symptoms of constipation, but this is severe enough that they will ask for help. They will come and see you. So when we think about constipation, the pathophysiology often falls either on the pelvic floor, neuromuscular disorders such as dyssynergia, or in impaired propulsive forces in terms of the erectile propulsive forces, or the patients who have colonic sensory motor disturbances. And these are the patients with the slow transit constipation or colonic inertia. For all these patients, you need to rule out secondary causes of the constipation, and having a good history is essential. Digital exam, a rectal digital exam is an important part of your evaluation. And for testing, you often start with the anorectal testing. Anorectal manometry, balloon expulsion test are the initial tests to consider. If the results are inconsistent, you will need to have the echography. And once it's ruled out, then you look for the slow transit constipation. And the reason for that is because we know that more than 50% of patients who have constipation, they have a form of defecatory dysfunction, whether this is isolated obstructive defecation or whether this is in combination with the slow transit constipation. You need to address the defecatory disorders in these patients first. In order to address the symptoms of constipation, you start with the habit training and then stool form optimization and biofeedback for the defecatory disorders. Let's talk about habit training, which is the most simple form of the behavioral therapy. Educating your patients about the anatomy, the need for the proper diet, fiber intake, hydration, these are very important. Scheduled toileting is another important part of the constipation management. There are some patients who are going to be resisting the urge, and they will have often problems with the constipation. And on the other hand, you have patients who are spending hours in the bathroom because of the urge sensation. Educating about all these bad behaviors is going to be very important. The proper sitting position, using squatting in some patients, diaphragmatic breathing, these are important aspects of the treatment. If they fail, then you will be working on the stool form optimization or along with the behavioral therapy. The first line therapy based on the AGA recommendation is fiber therapy, and the most evidence comes from the psyllium husk. Actually, inulin and bran fiber may be effective, but we don't have enough data to really go for those for recommendations. The byproduct of the fiber fermentation in the intestine is, of course, gas. So be aware that that might be an issue for patients who have IBS. And you may be starting with a very low dose in order to build tolerance in those patients. Many of your patients will ask about the probiotics. It's not really recommended by ACG, and the reason is because there have been a number of the studies who have looked at the probiotics in patients with IBS with constipation predominant symptoms, and they have had really conflicting data. So we really don't know if this is a good intervention for patients with the IBS. On the other hand, osmotic laxatives should be tried after the fiber. We have great agents such as polyethylene glycol, magnesium salts, and for some patients, eventually they may be doing better with lactulose, but we know that bloating is a big problem with lactulose. Stimulant laxative, including bisacodyl and sodium picosulfate, they can be very effective as rescue medications. The long-term use of them may be associated with some side effects. And Senna is another agent that was recommended based on the newest AGA guidelines. I'm sorry, sure. I have a lot of slides, sure. So the reason for Senna and magnesium to make it to the guidelines is best coming from this recent study that was showing their efficacy over the use of placebo. And as you can see, both agents were associated with improvement of symptoms of constipation and also quality of life and overall satisfaction. But I want you to look at the dose for Senna, which is 1 gram, and the magnesium oxide was at the dose of 1.5 gram. So this is not 8.6 milligrams Senna that we have available. And it's more comparable to the teas that are often used by the patients. In terms of the secretagogues, we have lubiprostone, linaclotide, and plecanatide currently available in the market. They have been very effective ion channel modulators working on the chloride channels to improve the load of chloride, followed by the sodium and water in the intestinal lumen. This is associated with this increasing the transit time and therefore loose or watery stool. The major side effect of lubiprostone can be nausea, and this is dose dependent and usually better tolerated if it's taken with food. Tenapanor is a newer agent that has become available. The mechanism of action of tenapanor is by blocking the sodium hydrogen exchanger number 3 in the lumen of the enterocytes. This is associated with significant load of water in the stool, and therefore there is a significant improvement in the intestinal transit. It has other mechanisms by improving the intestinal permeability and also decreasing the visceral hypersensitivity. If you ask about which one is better over the other one, based on this meta-analysis, it seems that linaclotide at the highest dose, 290 mcg, has the best efficacy, but this is followed by tenapanor, 50 mcg BID. But if you look at lubiprostone at the lowest dose and plecanatide, which is 3 milligram, these are not much different from the other ones, and they are all very effective in management of the symptoms of constipation. Let's talk about prokinetics. The only one that is currently available in the market is prucalopride, because tegoserad is not really manufactured anymore. It is effective. There have been a number of clinical trials in Europe. Its efficacy is significant for patients with chronic idiopathic constipation, and the side effects are usually limited to headache or abdominal pain, nausea, and diarrhea. In terms of the non-medical therapies, the vibrating capsule have become available since last year. Through the phase 3 clinical trials, over 300 patients where they had tried the vibrating capsule over the sham capsule, and they showed the efficacy in improving the symptoms of chronic constipation as well as quality of life. Transcutaneous electrical stimulation. It's more at the level of research. The AcuPoint ST36 has been shown to be effective in improving the colonic transit and effective for the management of slow transit constipation. Transcutaneous interferential currents have been used in pediatrics constipation and currently not practical for the adults. Another agent to be seen in the market soon is elobixibat. This is a bile acid transporter inhibitor. By the presence of the bile in the GI lumen, there is increased colonic motility and colonic secretion. This is associated with the decreased transit time and improvement of the symptoms of constipation. It's currently available in Japan and is going through the FDA approval here. When we are talking to our patients about the management of constipation, it's really important to understand what does your patient want out of the treatment. We have great options that are available to us currently, but I feel that we are underutilizing many of these options because of the perceived side effects. From the large number of the patients who had participated in the clinical trials, we have learned that over 50% of the patients with IBS-C or constipation, they are more satisfied with the loose and watery stools. So maybe this is something for us as a side effect, but it might be something that your patient is interested in. And this is very important for increasing the adherence to the medications, because we know that up to 20% of patients who were on lubiprostone, they had stopped taking lubiprostone within the first year. And over 10% of the patients on linaclotide stopped taking these medications because of the perceived lack of evidence. But when you looked at the people who had to stop the medication because of the intolerance and side effects, this was much less. So understanding what's the goal of the treatment to be able to manage these symptoms is very effective. It's also important to know because there seems to be additive effect in terms of continued use of these medications for management of the constipation. At least from these clinical trials from the linaclotide, we have learned that there are some group of patients, majority of patients who will respond to the treatment within the first 4 weeks, both in terms of the number of the bowel movements improving and abdominal symptoms improving. But there will be a group of patients who may see the effect of the medication after the 4 weeks. So if they stop taking the medication too early, we may not be able to really benefit from these medications in these patients. And adherence, again, is a big issue in these patients. Let's talk about biofeedback therapy, which is the only evidence-based treatment for patients with defecatory disorders. The goals of biofeedback therapy is to improve the anorectal coordination. This is often achieved through the use of the anal EMG. Also improving the evacuation through the use of the rectal balloon is another important part of the biofeedback therapy. In patients who have rectal sensory dysfunction, balloon training to correct the sensory function of the colon is also to be considered. Many of our people who are currently providing pelvic floor physical therapy in the community are not using biofeedback therapy. And I feel that this is the major hurdle in treating the patients with the defecatory disorders. Otherwise, from the clinical trials, we have noted that biofeedback therapy is effective. It's effective in improving the symptoms of dyssynergia with an odds ratio of 9.4 and is superior to non-biofeedback therapy for overall symptom management with an odds ratio of 3.6. The rate of success through these clinical trials is 60 to 70%. It has sustained effects over 2 years. And from one clinical trial, we have learned that home biofeedback therapy can be just as effective as the office-based biofeedback therapy. Of course, the effectiveness depends on the patient's enthusiasm in participating in this therapy, and also patients who have true pelvic floor dysfunction with abnormal balloon evacuation, patients who have higher anal tone, patients who are complaining of harder stool and digitation. These are the more likely to be improving the outcome of the biofeedback. Patients who are failing to respond to the true biofeedback therapy may be utilizing the suppositories, enemas, or transanal irrigation. These interventions have been less utilized in the US. Most data comes from Europe. And as you can see, the bowel satisfaction score in a retrospective study of more than 300 patients who had constipation improved with the large volume rectal irrigation after 6 months. In a prospective study, as you can see in the middle, The improvement of symptoms of constipation with the associated improvement in quality of life and general satisfaction was significant with the large volume transanal irrigation in over 500 patients. Many patients will be interested in using botulinum toxin type A for the management of dyssynergic defecation. There have been a number of studies and clinical trials. The efficacy and the adverse effects have not been consistent, and the data is not clear. And overall, the evidence to support the use of the botulinum toxin for dyssynergic defecation is poor and not recommended. So in summary, if you have a patient with chronic constipation who is not responding to the common medications, over-the-counter medications or prescription medications that we use, we need to identify the subtype of constipation in these patients. We often start with the pelvic floor testing, anorectal manometry, because this will be determining the management with the need for biofeedback therapy. Otherwise, if the pelvic floor dysfunction is ruled out, utilizing transit studies, mainly SITS marker, can appreciate the patients with the slow transit constipation. The management of the constipation with the wide variety of the medication, including the prosecretory agents and prokinetics, is often recommended for these patients. Patients who are failing to respond to these therapies, they can resort into the rescue therapies, transanal irrigations, and suppositories. And surgery should be reserved for a very small, less than 3% of your patients with constipation. And to remember that majority of your patients with constipation will respond to the habit training and lifestyle modification. We have great medications that can be utilized for patients with moderate constipation. And for patients who have severe symptoms of constipation, these are the patients who will need to have a multidisciplinary approach. And addressing the DGBI disorders with the brain being part of this axis is very important in these patients. And getting the psychotherapy psychiatrists involved in the management of these patients will be essential often. Thank you.
Thank you, Layla. That was fabulous. That was really great. I didn't realize we had Stanford kicking us off. That was not intentional, but it was really fortuitous. I'm really glad we had both of you here. That was a good way to start our morning. We have 10 minutes or so for questions. We got two smart people up here. We got microphones over there. Questions from the audience? Yes, sir.
Hi, good morning. Thank you. Excellent talks. Question on intestinal ultrasound. I've heard contradictory things about whether existing CPT codes allow for reasonable reimbursement, and then there's always a question of capital expenses of the equipment. What's your understanding of that aspect, and then what do you recommend for people who want to take this up? How do you go about that? The current best pathways for that? Thank you.
There you go. It's a great question. I mean, we're still struggling with that ourselves. We're sort of in the education phase of getting a couple of our providers going in that, and then potentially moving forward. But certainly UCSF has a program as well in intestinal ultrasound. The reimbursement's gotten a lot better. I think there was some question mark like maybe 3-4 years ago of where that would go, but there are limited abdominal ultrasound CPT codes, and I can provide that to you, which can be used for billing. And I know that there's a number of centers across the country that are doing that. You're right. The biggest hurdles currently, there's two, in my opinion. One is the equipment, and you're absolutely right. I mean, I think some of the bedside with the lower resolution may not necessarily capture what you want to capture as far as the bowel wall thickness. And then the other piece is education. You know, there's no licensing group in the United States. And so we rely largely on modules through the International Bowel Ultrasound Group. And so there's 3 modules where you do a weekend called Module 1, then you do 60 or so exams as Module 2, and then take an exam at one of our national conferences to be certified. So I think that those are kind of the 2 big hurdles in my mind. I think for practices that are interested in incorporating intestinal ultrasound, I think the current models across the country are to have 1 or 2 specialists that are certified. And they have their own clinic where they're doing point-of-care ultrasound, seeing a patient. But they also have purely intestinal ultrasound, an internal referral system where they might have a half a day of just doing ultrasound as surveillance. I think that's the current model. It's very different in Europe and other places like in Canada where everyone is trained as part of their GI training. But I think the current model, once you sort of get past the cost of the device, is probably to have one expert, at least currently, and then get into that training program for the modules through IBUS.
Thanks, Ken. Yes, sir.
Hey there.
Hi, John. Thank you.
Sachin, this is a wonderful. I'm over here on the left. Sorry. Thanks for your wonderful talk. Regarding the interrectal manometry and assessment of pelvic floor dysfunction, how important is the balloon expulsion versus the other parts? And how do you actually do those tests in your shop?
Sure. So we often start with the anorectal manometry to look for dyssynergia or the propulsive forces. And this is done in conjunction with the balloon expulsion test. And if the results of the two tests are not in concordance, otherwise, if you have a patient who looks to have dyssynergia, but the balloon expulsion test is normal, this is where you resort to use the deficography. And this is how you can see if the dyssynergia is confirmed through the deficography. And this is confirming the true diagnosis of the defecatory disorders. But if the results of the two tests are in concordance, definitely this is where we have a solid diagnosis of defecatory disorder, and the recommendation for the pelvic floor biofeedback therapy is made through that, if I'm correct.
Thank you. Yes, ma'am.
Hi, my name is Victoria Young. Thank you so much for the excellent talks. I'm a community gastroenterologist in the East Bay. I have a two-part question for Dr. Kashyan. With the insurance companies dictating changes in adalimumab, is there any concern if they're, I know that's okay to do like one switch or two switch, but then if you think about how they make us change PPI so often, are people in the IBD space worried about multiple switches within a year, like 2-4 switches in a year? That's my first question. And then the second question, how are you counseling patients? Because I would imagine I would get an influx of in-basket messages. And so how are you managing it? Do you bring patients in, or do you send a general letter?
That's two great questions, and we're struggling with that ourselves. So I don't mean to say that we have the solution. So one thing I would say is that the good news is we're sort of well versed in this because of the infliximab background, right? And I think that the difference was that the infliximab did not have any sort of pharmacy-driven interchangeability designation, unlike some of the adalimumab biosimilars. And so one or two of these agents are going to have this label of interchangeability, which means that if you sort of dispense, based on pharmacists, that they would automatically make that change depending on the plan. So I think that as far as the volume of in-basket messages, I think that's going to be there. But we're struggling with this as well. And what we've tried to do is send a My Health message to our patients who are on adalimumab to sort of make them aware of this. So we have initiatives there at Stanford to sort of work on this. But I think that to me, I think an awareness is necessary. And then I think your other question is a great one. There are a number of these multi-switch studies, right? I'm not a big fan of multi-switch. I'll be honest with you. I mean, I think, yes, it's probably sort of, and less so because the evidence for the multi-switch looks pretty good. Again, they're not huge studies, but they're good studies that suggest the multi-switch is there. To me, I think it's sort of, especially for the patient who's been well on a therapy for some time, to sort of do these multi-switches is really difficult on them to sort of understand that that it is the same medication essentially. So part of it is education. I do talk to them about that, but fortunately, I haven't run into this issue where, I switched to a biosimilar and 3 months later, they're asking for a different biosimilar. I do think there tends to be stability in these plans as far as coverage. But I think, just because this is starting to roll out, I imagine we'll have a lot more to say about this probably in the next couple of years. But I have not been successful in keeping either the originator or the biosimilar in terms of evidence? Because I think most of the evidence suggests that there's relative equivalency in terms of monitoring and in terms of use. I hope that answered that question.
Thank you.
Can I ask Layla one question if there's no one at the podium? So Layla, in IBD, we talk about combination therapy a lot, right? Thiopurine and infliximab. So I have a number of refractory patients, particularly older patients with constipation who've had maybe a partial response to one of the secretagogues or some of that. What's your opinion on, as opposed to calling it quits on one mechanism, adding a second mechanism, any concern about safety? I'm sure there's concern about approval by insurance, but have you had much experience with that, or how do you approach that situation?
Thank you. That's not uncommon for many of these patients with severe constipation or even moderate constipation to be on multiple different agents for addressing their symptoms. And we usually want to use different classes of medication. So often staying on the osmotic laxatives and adding a secretagogue in adjuncts to the over-the-counter therapies are recommended. The AGA guideline that came out last year, they actually recommended that the prosecretory agents be used as an adjunct to the over-the-counter laxatives. So this is perhaps very common and safe, and we see more and more patients who will require more than one therapy. We technically don't want to use two different medications from the same class. So if your patient is already on linaclotide, adding the plecanatide is perhaps not the best option, although there are some patients who are coming and they are on lubiprostone often and linaclotide. And the bottom line is that adding and using different layers of the medications is not a problem for majority of these patients. But what is really important is to understand that many of these patients who have resistant constipation, they have pelvic floor disorders, and the treatment of their symptoms of constipation will be relying on the proper biofeedback therapy. And adding more and more of the laxatives is less likely to be helpful in these patients.
Thanks, Layla. I have a question for you too. You're obviously popular this morning. So one of your slides described biofeedback as the only therapy, and that's a problem, right? Because it's the only therapy. And while you guys are great and there's other centers around, it's hard to get routine, repetitive biofeedback in the community, and yet it's the only therapy for this in some level. So please elaborate, if you will, on home biofeedback, because that's super exciting for me. You guys help us a lot, but you're limited and CPMC is limited. And there's just not free access to that service, unfortunately, open access. So tell me about home biofeedback. I'm looking forward to that.
Right. And
professionally.
This is exactly. Thank you for clarification. So you are hitting on the nail, and this is exactly the problem that we are currently having in the communities, where there is a divide, I feel, between what we know as gastroenterologists as the proper treatment of the pelvic floor disorders and what's really happening in the pelvic floor PT and in their practices. And we have not been able to penetrate them to really be able to be effectively offering what we know is the treatment of choice. The home biofeedback therapy, the study comes from Dr. Rao's group, that they utilize the device, the EMG, the rectal EMG, for addressing the biofeedback therapy. And they are the patients who will require some training. So at least one session is required to train them how to utilize the EMG biofeedback device. And there are services available. The EMG machine that they use currently available for renting. And there are also more affordable options. That is, the price is roughly around $300 of a unit, or $50 per month that you can rent the device. You need your physical therapist to be able to show the patient how to use it. And then the patient will be using the device at home, trying to master after the anorectal coordination, there might be some visits required in between to, again, coach the patient regarding how to utilize the EMG biofeedback. But this is definitely very helpful in terms of reducing the need for the numbers of the visits to your precious PFPT, and definitely effective. Again, it's a little bit of a challenge to get the providers, the PT providers, to buy into your recommendations, but definitely something that we are trying to make them aware of and to make them to help us with our patients with that.
Super. Well, thank you both. Anything else from the group, from the floor rather? All right, Stanford, you kicked us off. Thank you both so very, very much. Appreciate you. We're going to keep going. We'll have a break after this next talk because it's going to be a little bit of a tour de force. Our next speaker, of course, is our keynote speaker and a friend of mine for a long time. He's got a very long CV, and I'm not going to tell you everything about it. One thing I did notice is you're not been to Stanford. You've been to a whole lot of places, but you've not been where they are. John has been to New Mexico and Michigan. And he's one of those annoying people who walks around going, "Go Blue," every time he meets another Michiganer. Almost 20 years ago now, exactly. John trained at UCSF up the road, but about 20 years ago, almost now, you came back to UCSF and took over my office, actually. So we have a 20-year-ago transition where I left an office and he took over, and he spent some time there. He subsequently moved up to Washington to be the chief of GI at University of Washington in Seattle, and then about 4 or 5 years ago, got pulled over to Utah to be the chair of medicine as well there. Somewhere in the middle of that, you were president of the AGA. I don't know how you fit that in. One anecdote I'm gonna share, and you can tell me if this is true or not. So John does kind of outcomes and data research, and when John came and visited and interviewed in our place, and he literally took my office. I mean, actually my office, which is a lovely office at San Francisco General, and it looked out on a garden. We had a little courtyard and the like, and it wasn't giant, but I think I just got new furniture, so it was relatively well, little table, desk, and whatever. And John came in, he met with the department administrator, and he was all getting set up. And I got one message that everything was okay. We were like paving the way for your arrival, but the only deficit, the only thing we didn't have enough of for you was monitors. He needed a wall of flipping monitors for the spreadsheets that he does, and we were inadequate in that. But I think we upped our monitor game for you, and 20 years later, here we are today. So John, thank you for coming out and joining us today. We appreciate it.
Great.
Sir.
Neil, thanks so much. And that is actually very true. There are a lot more stories about San Francisco General back then, and I think there's Stan Huey in the audience out there. Stan and I actually were fellows together. Oh, do you need you need your phone? Actually, I was interested in looking at your phone and seeing old pictures. And anyway, it's great to be back. I spent 16 years here, 11 years in training. That's medical school residency and fellowship, and then some year of remedial work. I was gone 10 years and then was actually back on faculty. So thanks so much for the invitation. And Marina and the rest of the planning committee, thanks so much for having me here. And so this is my disclosure. I do have a research program, and I have a study with Exact Sciences and the American Cancer Society. I won't be talking about that here. Well, I want to talk a little bit about Utah. It's a beautiful place. That's not me skiing, but one of my friends. I'm actually buried in the snowbank right behind him, but that would be me. It's beautiful. You know, you got Arches, Canyonlands, Zion, and it's an interesting culture. There's a predominant culture. They still have, but they can make fun of themselves. So come out and visit. You get lots of hiking, biking, snow, and some pretty good breweries. Anyway, the agenda here, I'm actually going to talk about current colon cancer screening guidelines, evidence supporting colon cancer screening, and in particular, does colonoscopy actually work? I have a particular interest in understanding adherence to colon cancer screening strategies. I'll talk a little about the newer blood-based screening. I don't think I have time about the microbiome unless we have questions about that, and understanding how we're going to get to the goal of 80% screening in all populations. The important part about the USPSTF is if you get a grade A or B, then CMS and basically all the insurers will pay reimburse us, but also for screening, they'll reimburse us without any kind of copay for the patient. So the newest guidelines are for age 45 to 49 plus 50 to 75 years, grade A or B. That's a start. And then age 76 to 85, a grade C, kind of dependent on the comorbidities of your patient, and just stop screening after 85 years. Again, this is not surveillance, this is just screening. And in terms of what you screen with, it's a menu, a stool-based test, including a fecal blood test that includes either a fecal immunochemical test or FIT. And there's also this guaiac-based sensitive test, but I don't think anybody uses that anymore. Or the FIT DNA testing, or Cologuard, every 1 or 3 years, although it's reimbursed at 3 years. And then direct visualization tests. They still have down their sigmoidoscopy. It's been years since I've seen anybody get a sigmoidoscopy. And CT colonography generally isn't covered. So it really is colonoscopy every 10 years as the alternative, or the mainstay, I would say. The U.S. Multi-Society Task Force actually has the same menu, but they tier them. In many ways, it's kind of clinically what we do, either a colonoscopy every 10 years or an annual FIT. The ACP came out with some interesting guidelines just last year, and they basically kind of threw a little wrench in the whole system. Instead of every year FIT testing, they said every 2 years. There's not a whole lot of rationale, other than there's some clinical trials that look at that, but it is odd that they went from 1 year and they said every 2-year FIT testing. The other part that was quite controversial is they went back and they said, no, we're not going to screen people 45 to 49 years old. There's no clinical evidence. It was based on these modeling studies. Full disclosure, I'm part of the modeling studies that are done by the NCI, and we can talk a little bit about that. But they're the outlier. The other American Cancer Society, American College of Gastroenterology, and the AHA all have screening that starts at age 45 and annual FIT testing. So what are the evidence? Well, there's a lot of actually multiple randomized controlled trials showing that some type of fecal cord blood test, whether FOBT or FIT, has a 20% reduction in colon cancer incidence and up to 33% reduction in colon cancer mortality. FLEX-SIG, again, we don't do these anymore, but same kind of thing, 21% reduction in incidence, 26% reduction in mortality. And there really are no studies that really evaluate colon cancer incidence or mortality for stool DNA, CT colonography, colon capsule, or blood-based biomarkers. But there is a study now looking at colonoscopy, and this is the Nordic trial. It was a pragmatic randomized controlled trial, pragmatic because actually the intervention was not truly colonoscopy, it was an invitation to colonoscopy. And we'll tell you why this is important in a sec. And it was done in 4 countries, Norway, Sweden, Poland, and the Netherlands. And the problem, though, is that during the course, politics changes everything. In the Netherlands, you can't get data from people who are in the control group because they were really never actually got conformed consent from them. So the Netherlands couldn't report their data. It's kind of nuts. So the data we have is only from Poland, Norway, and Sweden. So these are the average risk for colon cancer. They start colon cancer screening at age 55. And the intervention was an invitation to a single screening colonoscopy or no invitation. All right, so that's important. And the endpoints were colon cancer incidence and mortality over 15 years. Now, this particular study that's reported in the New England Journal is only a 10-year. It's an interim analysis. So keep that in mind too. So the results are these. They had 84,000 patients who were randomized from Poland, Norway, and Sweden. And the important part is only 42% of the people who were invited to colonoscopy actually got the colonoscopy done. Right? So remember, the intervention was an invitation. So less than half the people got their colonoscopy. The other part is the adenoma detection rate. And for those who are gastroenterologists, this is the proportion of patients who are at average risk for colon cancer and whom the colonoscopy finds at least one adenoma. Right? The usual standard we have is at least 25%. And certainly here you can see that the ADR for the entire study was 30%. But you can see a lot of variation, right? So Sweden was only 14%, Norway is at 27%, Poland actually had the highest rate at 35%. But there's a caveat there. There seems to be differences in quality between the different countries. And here are the main results, right? And so the axis is a little bit different. You look at the x-axis is years since randomization, and the y-axis is actually the risk of colon cancer. And the big axis, you could barely see the differences because the rates are so low. So they blew it up in that little box right there. And you can see compared to the usual care, which means people who didn't get an invitation to colonoscopy, that in the red, the people who got invitation, there was initially an increase because this is people who get colonoscopy and you find cancers who are early stage that aren't symptomatic. It always happens in screening. And you can see that then about 6 years, it took 6 years, but then you have this reversal so that colonoscopy prevents colon cancer by removal of polyps. And certainly the risk reduction in colon cancer was 18% at that 10-year point, but they didn't find a difference in colon cancer mortality. And if you looked at that, the number needed to treat for incidence, in other words, the number needed to invite for colonoscopy to prevent one colon cancer case was 455. So that doesn't look so good. But then remember, it's like, gosh, only 42% of the patients actually got their colonoscopy done. If you look at the people who got it done, it looks much better, right? The colon cancer incidence, the risk ratio is 0.69, which means a 31% reduction in colon cancer. And the colon cancer mortality reduction was 50%. So a 50% reduction in colon cancer mortality if you got your colonoscopy done. So what does this mean? A couple of things you got to remember. Remember the ADR, 30% overall, but many endoscopists were less than 25%. The question is, were they doing a good job with colonoscopy? Was the colon actually clean? Were they getting to the cecum? Were they detecting and removing all the adenomas? And if you have an ADR less than 25%, suspicion is not, all right? Now, again, this is a 10-year follow-up. The 15 years is actually the primary specified outcome. And so I'm part of SysNet, which is a computer simulation program that's funded by the NCI. And we've done some modeling analysis, and we certainly see that, well, gosh, by 15 years, we should actually get to the outcomes we expect, which again is more closer to 60 or 7% reduction in mortality. But we'll see, right? And now the other thing that's interesting, so actually I had the chance to talk with some of the primary authors, actually Michael Kaminsky, who's the last author, and Michael Bredhauer, who is the first author. And the stuff that doesn't get in the paper is quite interesting. If you talk to Michael Kaminsky, the interesting thing is that colon cancer incidence in colon was actually decreasing during this time, even in the control population. And they don't do a lot of, at that point, they hadn't done a lot of screening colonoscopy. So there wasn't a lot of crossover. It just was the incidence was reducing. They don't know why, but if they have a lower incidence in the control group, it's really hard to find a big difference in your intervention group, right? So all these things are part of this. So the intention to treat analysis, got to remember, it's an 18% reduction in colon cancer incidence, no mortality benefit. That was a big kind of thing that got out in the news. The protocol analysis shows a 31% reduction in colon cancer incidence and a 50% reduction in mortality. So my interpretation is you get a colonoscopy, it works. And compared to prior data, works better than FIT or FLEX-Sig. And it's expected to have even better results by year 15, which is the actual planned primary analysis, and adherence is crucial. So adherence is what I work on. And it was by accident that I got to there. And I'll tell you a little bit why. And so some of these are the data that we see, like here on the left is the BRFSS. It's the Behavior Risk Factor Surveillance System. In 2020, only 69% of people eligible in the US were getting their colonoscopy done. It actually gets worse in the left panel here. This is the federally qualified health centers, people with Medicaid or uninsured. You can see here that the rates are in the 40s. Only like 40% of people are getting colon cancer screening. And it dropped, of course, during the pandemic. We still haven't gotten back. And on the right panel, the only group that actually has adherence rates at 70% is the Medicare population. And so we're nowhere near the National Colon Cancer Roundtable goal of 80% adherence in all communities. So I think this is really important because not only are we not getting there, we're not getting our patients doing a test that we know works. The disparities based on racial, ethnic, economic issues makes these things worse, all right? And so I looked at adherence and choice. And this is a prospective quasi-experiment trial that I did, gosh, about 20 years ago in the San Francisco Community Health Network. The interventions were basically we randomized entire clinics to one of three things. We recommended they get FOBT, recommended the patient to get colonoscopy, or gave them their choice. In the setting with the San Francisco General Hospital, actually it's now called Zuckerberg something. I mean, I'm trying to figure that one out. And the San Francisco Community Health Network. And it was a racially diverse and medically underserved population. And the participants were at average risk, meaning they didn't have a family history, no prior history of polyps or cancer, no IBD, and they weren't up to date with screening. And the outcome we looked at was, gosh, did they get their tests done? Did they get their FOBT done? And if it was positive, did their colonoscopy? Did they get their colonoscopy done? Right? And we looked for a whole year of adherence after we randomized them. And the whole clinic was randomized. So we didn't have to actually get individual consent from the patient because even if they didn't participate in the trial, they still got whatever was being done in the clinic. It's kind of goofy, but it took me a year to get that one through the IRB. And so here we got almost 1,000 patients re-enrolled, and I keep talking this is a majority minority. So 34% were Latinx, 30% Asian, mostly Chinese, 18% were Black individuals, and only 15% were white people. And so the outcome was here. And it was very surprising because for me as a gastroenterologist, I figured, hey, colonoscopy, that's the way to go. There's no way he's going to back off. And if I tell people to do a colonoscopy or my PCPs want to do a colonoscopy, they get patients done. As it turns out, 2/3 of the patients who were told to get FOBT got it done. 2/3 of the people who were given a choice between colonoscopy and FOBT got it done. But only 38% of people who were told to get colonoscopy actually got it done within the following year. And this is surprising because we gave them all kinds of things. We made sure that their prep and the instructions and the scheduling was done in their primary language. We gave them the ride. If they didn't have a ride, we spoke to them in the language that they preferred. We gave them instructions not to them, to also their family. And only 38% of the people showed up for the colonoscopy. And the worst thing was, even if you're in that group, you're told to get colonoscopy, and then ensuing year, we could still let them get at FOBT. Only 58% of the people got it done, still significantly less than the other two groups. And this was really disappointing because I'm a gastroenterologist. I actually thought colonoscopy was the best. That was the whole point of doing this study. And the other part that was interesting is that the whole sequential thing of saying, oh yeah, I do a colonoscopy, if you don't want to do that, then maybe you can get an FOBT. That kind of sequential idea of here's the best test, but if you want to do it, here's a secondary test. That didn't seem to go over very well, this group. But the other thing that was really interesting was different by different racial groups. And this is actually set up by the four big columns are white, Black, Latinx, and Asian people. And then you have the FOBT group on the far left. The middle group was the colonoscopy group. And then you have the right one is actually the people who were offered choice. And in the white bar is the FOBTs that were done, and the black bars are the colonoscopy. And you can see here that what drove things were the minority patients actually preferred to have FOBT, whereas the white individuals, participants, actually preferred to have colonoscopy. That was borne out also in the choice, where the white individuals preferred to have colonoscopy and the non-white individuals preferred to have FOBT, the non-invasive test. And so that was quite interesting. It really gave me the idea that choice is better for everybody, right? Then we did a follow-up study. The next 3 years, we followed what we did. And this was actually done by Peter Liang, who was one of my fellows. And we followed them. But the other thing that happened was that we didn't really do any intervention, navigation. We didn't really push them to get anything done after the first year. And so the primary outcome was going to be annual FOBT, 3 sequential cycles, plus a colonoscopy if the FOBT was positive, or one colonoscopy during that initial 12-month observation period. We had a secondary idea that, well, let's do this biennial FOBT. Every year there, that'd be good enough. We'll show those. So the first group is the same as my first year study, where on the left is FOBT, in the middle is colonoscopy alone. On the right column is actually the choice. And you can see here that 2/3 either with the FOBT or the choice group had it done. Only 38% of those randomized to colonoscopy completed their test. And the interesting thing was that over time, the patients who were randomized to the FOBT had a lower and lower overall adherence. So only 14% of the people who were randomized to get FOBT actually got all 3 rounds. So initially it was 2/3, but trying to get people to do it 3 years was really tough. especially without any kind of navigation. This is also, you can see the same thing in the choice group. Even if you look at doing things, okay, biennial FOPD is fine, you can still see a diminution. And so there's degradation in adherence over time, especially without navigation. And by year 3 of this study, adherence to FOPD dropped below adherence to choice or colonoscopy. And so I think the following. I think providing a choice of colon cancer screening tests, it can increase adherence, but it does varies by race or ethnicity. Now, we know this is a surrogate for other stuff like health belief, family, community values, all those kinds of things. But certainly the Asian, Latinx, and Black individuals adhere more often to FOBT. And intervals make a difference, right? Annual testing requires really intense navigation to keep people going, right? Long-term adherence to colonoscopy overall, if we can get that done, is good because it's like 1 and you're good for 10 years. So those are the issues that I think are really important. So with adherence as a background, if we're really trying to adherence, I thought, well, or this idea about blood-based biomarkers. Well, heck, we get blood for everything. PSA tests, if you get those things, lipids, all those other things. So I think it seems pretty easy. For most of us, we think, well, gosh, adherence to a blood-based test should be much higher than for, poking a stick in your poop, right? Or have you seen the Cologuard? You got to have a whole load of that thing you got to send off in the mail. It's pretty hard to do. So what about a blood-based test? So there's a couple of them. I'm just going to give you a particular example. This is the Shield Guardian Health. I don't have any disclosures with this. It looks at proteomic, genomic, and epigenomic markers. And they've actually published a prospective cohort study of almost 23,000 participants for an average risk for screening colonoscopy. And so these are the test characteristics. There's a 83% sensitivity for colon cancer using one test, right? A specificity of 90%. That's pretty good. The one thing you got to look at is a sensitivity for advanced adenomas. Advanced adenomas, for the people who don't whack out adenomas like we do, large adenomas or things that high-grade dysplasia or villus, things that we think are going to turn into cancer right away or very close. Those are the ones we worry about. Only 13% detection. Really important. Think about that, right? Okay. So if you look at this and think about blood-based biomarker like the Shield compared to other things. Here's some comparison. Now, this is not a fair comparison because I'm pulling different systematic reviews. But let's say focus on the left side. The sensitivity for colon cancer, really high for blue, that's a colonoscopy. Really high actually for Cologuard's, 94%, and that's in the orange. The FIT per test is 74% sensitivity for colon cancer. And the Shield, as we just saw, over 80%. So it looks pretty good, right? But then the next column is really, really important. This is the sensitivity adenomas that are large, over a centimeter, things that we think are going to turn into cancer. Highest for colonoscopy, Cologuard, about 42% sensitivity for these advanced adenomas. Even FIT gets about a 22% sensitivity. But the blood-based tests, only about 10 to 12%. That kind of makes sense, right? If you got a polyp, why would you find stuff in the blood, right? By the time it's stuff in the blood, it's probably like metastatic. So, but think about that. And so part of my group, which is an NCI-funded program called CISNET, we have 3 independent simulation modeling groups, and we simulated these things. Now, again, we didn't have tens of thousands of patients we did, but we did these simulations based on the existing data. And we had blood-based screening. You can see them here. We used different sensitivities and specificities. And the thing that CMS has done is said, basically, we'll reimburse for a blood-based biomarker for colon cancer if it looks a lot like FIT. And there was a systematic review by Jeff Lee, who was at Kaiser and UCSF, said that, gosh, if the FIT basically has about a 74% sensitivity for cancer and a 90% specificity for cancer. So CMS said, if they got that, we'll cover it. In fact, they did. We'll talk about it in a sec. We compared that to no screening, and we also compared it to colonoscopy and FIT screening at usual kind of intervals. And so on the left thing, you can just see on the red bars, it's kind of like the test we have right now. So the biggest red bar is if you didn't do any kind of screening at all. And the most left kind of column is colon cancer cases. And you can see in the orange and the pink, you can see if you do FIT and colonoscopy, many fewer colon cancer cases. And in the next column, many few colon cancer deaths. compared to the red, you get the kind of the orange and the orangish thing. Now, the blue ones are all the variations of the blood-based biomarkers, and they work, meaning that they have fewer cancers and fewer cancer deaths than if you do no screening, but they're not as good as colonoscopy or as at the FIT. That's very interesting. And so the question is why? Now, this is a little bit of a wonky slide, and this is the stuff I do, and which is actually just published in the journal Gastroenterology. But these are the three models. I'm not going to go in a lot of details, but the three columns of those. And on the x-axis, the costs. You try to want to kind of minimize costs. On the y-axis, you have these qualities of life years gained. You want lots of those, right? Then you can see here in each case, there's like something that says no screening, so little x, kind of there's 0 toward the bottom. Compared to no screening, you can see that FIT, which is the orange thing, and colonoscopy is the red thing, many more life years gains, right? Actually, FIT is actually less expensive. It's cost savings. You have less expense and more benefit doing FIT compared to no screening. It's pretty cool. And the reason for that is because treatment of really end stage colon cancer is really expensive with all these, immune therapies and stuff. Colonoscopy is actually more effective than FIT, meaning that it has more life years gains, kind of more expensive, but still better, right? But then you look at these other ones, all the blue things. All the blue things in every model, this is modeling the blood-based biomarkers of the various kind of permutations in the sensitive analysis. And every one of these things you can say, yeah, sure, compared to no screening, which is the X, you got more life years gained at some cost. It's like, sure. Compared to no screening, if there was no other test around, it would be cost effective. But you can see compared to either FIT or colonoscopy, it's less effective and more expensive. What is it? I guess you're that way. But the bottom line is if you're less effective and more expensive, it's called what you call you're dominated. You don't do it. It's like a no-brainer. So as long as somebody's willing to do a FIT or colonoscopy, forget the blood-based test. You're going to lose benefit, right? Bad thing to do. Less effective and more expensive than FIT or colonoscopy. So we did some things that you don't want to get a lot of details about. We tried to figure out, well, how good does a blood-based biomarker have to be equivalent to their FIT or colonoscopy? And so the first thing was forget costs. Just figure out how many lives you're going to save. And to achieve equality, whatever it is, the blood-based biomarker sensitivity to advanced adenoma has to be greater than 20%. And you got to do it with annual screening. Near the baseline, these things are like $1,000. Maybe you don't know that. Look it up. $1,000. So that's why I say, we do it every 3 years. But if you need annual screening and you have to have a sensitivity greater than 20%, the baseline is about 10 to 12%. All right. And to achieve non-inferiority and cost effectiveness, you put costs into the thing. You got to have a sensitivity to advanced adenoma is greater than 40%, and you get it every year. And the blood test can't cost $1,000, but it's got to be less than 125. And so those are the important things. And, until we get a blood-based test that has that kind of sensitivity for advanced adenomas, it's not going to be effective or cost-effective compared to FIT or colonoscopy. So I'm going to kind of finish up on what will it take. So what will it take, meaning what will it take to actually achieve the National Colorectal Cancer Roundtable goal of 80% in all communities? Well, I think it'll take screening for all age-appropriate U.S. residents. We can't be dependent on insurance status, which is, of course, our entire healthcare system. We need a choice of screening strategies. No out-of-pocket costs, because that's a barrier for people getting their tests. We do need a national database to provide evidence-based follow-up. And I think we actually need navigators to assist in completing screening, surveillance, and treatment. And so one of the things that I was able to do, and again, not just me, but a variety of people who we advocated with, was the American Cancer Society, which I think everybody knows about, and Fight CRC. Fight CRC is a wonderful group of advocates made of patients and patients' families. And we met with CMS, Center for Medicare and Medicaid Services. And then we followed up with a variety of people. It's this Health and Human Service, which kind of makes sense, right? We're health. The Department of Labor, it's like, why them? And then Department of Treasury? We had to meet with the IRS. So nobody really who wants to meet with the IRS, right? I mean, you want to be below the radar. But it turns out, because of the fact that insurance is a benefit, and it's in our insurance programs across the country are based on employment, that's why we had to talk to the Department of Labor, because it's a benefit. And then once it's a benefit, we had to talk to the Treasury because it was part of compensation. And then we had to talk to IRS because that's the way the whole thing was just nuts, right? But the best part is not me or ACS, is Fight CRC. You've got these families of, like, I don't know, we may talk about early onset, 30-year-old women who died of colon cancer, right? And you had these stories, and I got to tell you, boy, they're heart-wrenching. And there's, like, you know, these people from these government agents are pretty stoic. No way they can hold it together when you hear these stories. So it really took a coalition of societies, Cancer Society, and then a patient advocacy group to do this. And the greatest thing was in January 22, they did release guidance for commercial payers. Our plans and insurers required to cover without imposition of any cost sharing follow-up colonoscopy conducted of a positive non-invasive stool screening test or direct visualization test. And the answer was yes. So no more cost sharing, no more copays, no more, it has to be covered without any of these things. So that was really pretty cool. And in fact, I've done things in my life, but I got to tell you, this is one of the most proud things. I got a letter addressed to me by Javier Becerra, who's the Director of Health and Human Services, saying, hey, thanks for letting us know. Really important. We've talked it over, and includes Janet Yellen, who was the Treasury, whoever was from the IRS, who I try to keep out of my mind, a bunch of other people from the government, and basically said, yes, it's important to actually have these changes, and we agree with you. Now, subsequent to that, this is actually for commercial insurers. Subsequent to that, we actually had a success with CMS. And so it takes about 3 to 5 years to actually phase out all the copays. But now we finally closed both loopholes. The loophole where it used to be a colonoscopy would turn from a screening colonoscopy to a diagnostic. You found a polyp, right? And now we also have a loophole. If you have a positive FIT or a positive Cologuard or a positive non-invasive test, you can get your follow-up colonoscopy done without any kind of copays. So I think those are really important things. I think in summary, the effectiveness. We think I've seen, or I've shown you, that there's effective colonoscopy for FOPT, for flexible sigmoidoscopy. Now, in colonoscopy, irrespective of what the press says, the colonoscopy will work, but you got to do it. And that, again, you got to understand the study design, but it does work if you do it. And which test is best? You know, as a gastroenterologist, we love colonoscopy. You got to send our kids to college. You know, there's stuff we do. We also inherently believe is the best test. I think all of us probably get a colonoscopy ourselves. But the best test really is the one that gets done. And not just the one that gets done, but done consistently, because I really do understand that adherence is key to all of this. And the future, it could include blood-based biomarkers. But the biggest thing is it's not actually the detection of colon cancer that will really dictate whether that they're effective or cost-effective. Right? It's their ability to detect the advanced adenomas, because interestingly enough, it's always better and less costly to prevent cancer than to treat cancer. And until these blood-based biomarkers can actually detect the precancerous polyps, it'll always be less effective and less cost-effective than the existing tests, including fecal chemical tests, right? And finally, access. I think it's going to be really critical that we create a national colon cancer screening program, because again, without an inherent a program that includes a national database, that includes choice, includes navigation, and includes some way to ensure that we have a reduction in the barriers to adherence to get these colon cancer screening tests done, we won't achieve our goal of 80% adherence in all populations. Thank again the organizers, Marina, my old friends, and thanks so much for your attention.
You're not dismissed yet. We'll keep John up for a few more minutes before we dismiss him. Now you know why you need so many monitors, right? It's all that modeling stuff. That's why we needed big monitors. Questions for John? This is a rhetorical question. I'll start, John. Why the hell did the New England Journal take the Nordic study? It's a horrible study, right? I mean, all it does is generate bad press, which is an invitation to colonoscopy doesn't save lives. Well, we know that an invitation doesn't save lives. Just because it looks good to have a colon cancer thing on the cover of New England Journal?
Well, I guess there's probably two parts of this. One is why I have an interim analysis.
Right.
Because I do believe actually when we did the modeling study using the data that they gave us from the Nordic trial, and when you get modeled out to 15 years, you will have actually a 70% reduction in mortality. So that's the first thing is that why have an interim analysis? Here, let me just let you know. So there are four randomized controlled trials comparing either colonoscopy to nothing or colonoscopy to FIT or something like that. This is just the first, and so there's a lot of excitement. There's another one there's another Nordic one, Nordic Light. There's actually one in Spain, and there's actually one in the U.S., a confirmed trial of other VAs. And so there was a lot of excitement because this is the first, and that's probably why they got their interim results published in New England Journal. But I agree that it is interim, and there's a reason. You can see that those lines are crossing. If you just wait a few more years, you'll see it. The other part is pragmatic trials. You're asking, well, why do a study of an invitation? Currently, I'm an editor for JAMA, and it's hard to do a trial where, oh yeah, you have to get a colonoscopy because people don't do what they're supposed to do. And so, and if you only look at people who get the colonoscopy done, it's a selected group. And there's a reason why people, let's say if you're invited to get a colonoscopy, there's people who do it and don't. There's probably a higher risk among people who actually get it done. So it gets kind of messy when you really try to do a study, does colonoscopy work? You're more likely to have studies that say, does an invitational colonoscopy work, and hope you get a higher adherence. So, yeah.
Thank you. All right, we got some questions.
More.
Hi, I'm Kevin MP from Kaiser San Francisco. Thank you for that talk. I actually had a question about a reasonable strategy for patients who've had positive stool testing like FIT, who decline colonoscopy and insist on getting another non-invasive test. Obviously, we don't recommend that. We recommend follow-up colonoscopy. Is any testing better than no testing, or what's a reasonable strategy after that?
Okay. I have to apologize. I have a cochlear implant and I can't quite hear everybody. So maybe you can you?
Yeah, I'm not sure I understood entirely either. It's hard to, we're echoing up here too. It's not just that, it's echoing a lot here.
So basically a patient who has a positive stool test, FIT, who declines follow-up colonoscopy, and they insist on continuing with a non-invasive follow-up or with another stool test. What's a reasonable strategy for them if they're not going to do their colonoscopy?
So someone who's got a positive FIT but doesn't want a colonoscopy, what do you do besides shake them and say, you should get a colonoscopy?
It's interesting. This question came up just last week. I had our NCI SysNet, and we're trying to figure out how to model this. And so my understanding of your question is, well, if somebody has a positive FIT or a positive Cologuard, doesn't get their colonoscopy, what do you do with them? And an interesting thing is, the bottom line is that we shouldn't be doing screening tests unless people agree that they understand if it's positive to get a colonoscopy, because the FIT itself, I mean, this is a kind of the whatever, that in itself doesn't prevent colon cancer. It's, again, the colonoscopy to detect polyps and remove them or detect a cancer at a curable stage that actually reduces mortality. So we thought about this, and there were some of the modeling groups that say, well, gosh, then you just kind of keep doing the FIT. And I said, that's nuts. If you have one FIT, you need a colonoscopy. And basically what you need is to keep nagging the person to get a colonoscopy. We don't keep doing FITs. Now, I'm being a bit facetious because this is a real world problem. And in the studies that I've seen, the adherence to a follow-up colonoscopy could be as low as 40%. And even Kaiser, it's probably 85%, not 100%. So your question is really valid. But we have to find a better way to get people to get that follow-up colonoscopy. I would hope that one of the barriers was, in fact, the copays. And now that we've reduced that or eliminated that, hopefully that barrier will allow people to get that follow-up colonoscopy. But I don't see any reason to
repeat a FIT or a Cologuard if you've had one. You just got to keep nagging that person to get that colonoscopy, right? Good. Does that stand?
Hi, John. On a personal thank you for helping me getting my follow-up colonoscopy.
Hey, there you go.
Question is, you have the insight as to why there's such a big difference with the willingness to have colonoscopy between the different ethnic groups.
Oh,
Why are the underlying ethnic groups? Did you dive
Yeah,
into
yeah,
that?
yeah.
Like, what's the cultural barrier to that?
yeah, it's interesting. And so this refers, I think, Stan, to the fact that the rate of uptake of different colon cancer screening tests was different. It was completely a surprise to us. And I think, again, race, ethnicity is a surrogate for cultural values, for community, for other things. But a big part of it, so actually, let's say in the Latinx population, there's this thing, machismo, and the idea of somehow poking stool or even have a colonoscopy was really antithetical to the culture. And trying to address issues about the culture would be most critical in terms of increased adherence. And in this particular case, the group who are the Latinx group were probably fine doing the FOBT just with the sample of the stool, but really were quite against having a colonoscopy done because that culturally was a huge barrier to them. It was also a cultural barrier when we're trying to get them to get their colonoscopy after a positive test. But we hadn't realized that. So that's just one example of how the race and ethnicity is a surrogate for some other cultural value or health belief. There are other health belief or subcultures that's like, it's done. Why screen? It is written. You can't change the outcome of health. And so screening is so kind of antithetical to their idea. So maybe we'll do a stool test, but we're never going to do something. So these are the kind of things that we have to delve into in much more detail and understanding why there are differences. Because again, these are surrogates for underlying health beliefs. Anyway, thanks, Stan.
Was there also a gender difference? Did you look at that?
Actually, we did.
Within those subgroups?
Yeah, it's interesting. The gender, there was not, the gender differences weren't borne out after you look for the racial ethnic differences.
You'd think they might be. I mean,
you would think
data is data, right?
Well, the other thing we thought was, women are much better at screening. There's actually breast cancer screening, cervical cancer screening, and those screening, anywhere 80 to 85%. I mean, they're really high screening rates. But the odd thing is that women also didn't screen for colon cancer. Mainly, I think there's this myth that, women don't get colon cancer. It's the lifetime risk of colon cancer is equal with men and women, even though that the age-adjusted rate is higher in men. Just women live longer, right? And so the issue is that the risk of death from colon cancer is the same among women and men. It just, again, it's not. I don't think it's portrayed that way. So the adherence to colon cancer screening is much lower than adherence to breast cancer and cervical cancer screening, which is really frustrating.
Yeah. Yes, sir.
Thank you very much. Excellent review. Two questions. Given with Cologuard, what seems to be a higher risk of false positives with age, methylation in tissue, whatever the explanation, do you tend to discourage that versus FIT in people who don't want colonoscopy for screening and still encourage the FIT? That's one question.
Let's take that one, and we'll get to the other ones.
Yeah, so it's fascinating. I'm not sure if this is exactly your question, but there is a play. I mean, if you look at the AUCs, right, of Cologuard in terms of the area under the curve for sensitivity and specificity. I'm not sure if it's exactly your question, but I hope it is, because there was an editorial a short report just published in JAMA. And it actually looked at that and said, well, if you just play with the area on the curve for FOBT or FIT, and maybe you increase the sensitivity and drop the specificity, you get the same numbers. And it was, it was the guy from Germany. He's been doing this well. And it's exactly, he showed this is that, wow, if you can get real close, if you just change the point on the AUC of an FIT, you can get close to a Cologuard. And you have, higher sensitivity, but you do drop some specificity. So is quite interesting. And of course, Cologuard, I think the retail is like $650. Medicare remits is $490, and the FIT I think costs $24. So was that your question? Because that was a fascinating thing, and we've actually got some report that was recently published.
Yeah, I mean, the question was really, should we be discouraging much older patients from using Cologuard as their screen versus yearly FIT because of the false positives, of the risk of putting them through maybe a higher risk colonoscopy, but not finding anything?
Yeah.
Just stop Cologuard testing at some. Should you discourage Cologuard testing after a certain age because of the significant false positive rate?
Yeah. So I guess there's two parts I like to address. One is the adherence, and with Cologuard having a 3-year, there's probably a lot of PCPs here. A lot of PCPs are switching to Cologuard because it's easier to hit their HEDIS measures because it's once every 3 years, and so we actually do see a higher up-to-date adherence with Cologuard because it is every 3 years. So that's one thing. The second part I think was, is there a way to look at age-related recommendations for screening? And it's fascinating. It's something that we can do with our modeling. And in fact, we haven't done it yet, but looking at something like, gosh, should we start with FIT? Can we move to colonoscopy? And then can we use something less invasive as you get older? Because again, if you've been screened and you've been negative, you're at a low risk compared to somebody who's older who hasn't been screened and you don't know where the risk is. So the ability to have tailored screening based on age and prior results of tests are something that we can do through modeling, and we proposed it for our next cycle. So yeah, we'll invite you to our modeling group. That's a great idea, to whether we have age-related recommendations that are most to really develop the most efficacious and cost-effective strategy. Haven't done it, but it's something we plan on doing. Thanks for that question.
Good. That does get to my second question, which is that population of patients we have quite a lot of who have had 2, 3 small adenomas or SSAs over multiple colonoscopies. They're now getting to age 80, 85. They're still in decent health. What kind of discussion should we be having with them about stopping screening versus invasive versus less invasive testing?
Yeah.
What's really the natural history in that kind of a group?
Aging out,
Yeah,
which is a fluid target, obviously.
I'd like to hear what the gastroenterologist group in this group do. Now, so I think in this particular case, not so much screening, but surveillance, people with a prior history of adenomas. And people kind of come in 2 flavors as far as when I see. You have people who you kind of farm them out, meaning that you do a bunch of polyps and then they kind of don't make many more after that. And you get other people who just continue to make adenomas and cell-serrated polyps. And it's hard to tell the difference in these things. My general thought, though, is that a good, high-quality colonoscopy where you're really removing all the adenomas, the benefit for that particular colonoscopy and reducing colon cancer is at least 7 years, right? Interestingly enough, if you have a negative colonoscopy, that negative benefit looks like it actually lasts 17 years. And so I do think there's a couple of things. One is that once you have an individual, their physiologic age is more important than chronologic age. I've met plenty of 50-year-olds just like, wow, why are we screening? Whereas I've met 80-year-olds whose family history is like, wow, they've lived 100 and they're in great shape. And I'll continue that. And so there's a couple of things there's one thing I do know is that physiologic age is more important than chronologic age. And if I think they're going to live, if that individual in front of me will live 10 years, and there's calculators that can do this, I will continue surveillance. The other part is I'd love to see us be able to find a way to put in prior surveillance findings into some risk calculator to determine whether the risk of cancer is high. And the other part, of course, is biomarkers. At some point, we'll hopefully be able to find different biomarkers, not the genomic, but also epigenetics and proteomics and any other kind of biomarkers to determine, is this person at a higher risk? Should we terminate surveillance if they're at low risk, or we should continue surveillance based on physiologic age? We're not there yet. I'm curious what other people do.
I'll tell you what I do, which is exactly what you said. It's physiologic age. It's a discussion. I don't talk about numbers with them at all. I talk about, do you have another 5 or 10 years to live?
Yeah.
And if we think you do, we're going. It's just all systems go. And if we don't, we don't. Segueing in from that, I just want to ask your opinion because I don't think you mentioned it. You probably saw in the last few weeks, given that 17-year interval after a negative exam in an average risk person, people are now talking about 15 years. That's not here yet, but that's the newest discussion is forget 10 years. How about 15? What do you think of that?
Yeah, no, it's there's a couple of studies that have shown this. The same group, Michael Brechtauer's group in Poland, a number of years ago, I think was published in Gastroenterology, showed that if you have a high quality screening colonoscopy that's negative, your risk of cancer is basically negligible for 17 years. And there's newer data again showing similar data. And I can't remember, I think it was US data now, that really do show that, again, if you're negative colonoscopy, meaning that you're a lower risk group, then that you can go out, 20 years. So I think that there is going to be a newer recommendations that if you have a high quality meaning, but you could actually see everything, got to the CECOM, the prep was excellent. We probably can actually go to a 15-year interval as opposed to a 10-year screening interval.
We took the 5 to 7. We'll probably take the 10 to 15. We're adding them at the front end and we're subtracting them on the back end. Kian?
Yeah, great talk, John. Thanks a lot. So piggybacking off the last question, so a patient with a positive FIT or a patient, more importantly, with a FIT DNA that's positive, and you do your good high quality colonoscopy and it's unremarkable. Personally, I feel very comfortable with the FIT test in terms of, positive, but a normal colonoscopy that supersedes it. My bigger issue with the FIT DNA testing is, unfortunately, I don't know if it was the FIT component or the DNA component that resulted in a positive test, which is why as Neil and some of the folks were saying, I've shied away from that test. But I just want to hear your approach to that. This is, a patient who's had a FIT DNA that's positive. You get a normal exam. Are you doing and no family history? Are you saying, come back and see me in 10 years? And then I have one more question if we have time, but if not, that's okay.
Yeah. So the point being, what do you do with a positive FIT DNA test with a negative colonoscopy?
Right.
The PAT answer, meaning the company answer, is that's as long as you were able to get to the CECOM, it was a high quality exam with a good clean out, then you should be into that. The negative test should be same as a negative screening colonoscopy, 10 years. The other, so this is the part where, so I did visit the folks at Exact, it's an amazing place because the whole thing's automated. They do have data about other kind of cancers because the stuff that's in the DNA stuff, there's some epigenetic as well as genetic. And there's this they just came out the FIT DNA version 2, right? And so the interesting thing is that there actually are some gastric cancers that kind of pop up in there. And in particular, patients who are actually of Asian descent, or at least anybody who's at higher risk for gastric cancer, people who had a history of H. pylori, come from an endemic area with gastric cancer, like Korea, Japan, actually some parts of South America. And the interesting thing is they did actually have patients who have gastric cancer. And so my thoughts are is that if you have somebody who comes from a high endemic area for gastric cancer, that doing an upper endoscopy is something that I would try to do. Now, you're not going to get reimbursed because if it was just screenings, it's not an indication, but almost everybody has reflux, right? Or dyspepsia. And you can always do you have dyspepsia? No, I don't have stomach. Do you never have it? How about heartburn? No, I never. Have you ever had pizza? Or kimchi, oh yes. So you can always, and this is very similar because it's about, gosh, even Stam can tell you, I think 20, maybe 20, actually it was at San Francisco General Hospital. Don Rocky, they published a paper, this is just plain old FOBT. Okay. And positive FOBT in patients from China, there was a higher risk of gastric cancer than colon cancer in people with, and I remember it was published, I don't know, it was a while ago. I'm trying to remember. I mean, Neil was there, I think Stan was there. And so we've kind of always known that in patients who either have high risk based on where they grew up, especially the risk of H. pylori, especially risk of family history, that's something I do kind of on the side. So that's caveat, but I can't say that as part of I don't know, I couldn't say that officially, but that's something I would do if somebody is at higher risk of gastric cancer based on a
I'd love to see that in some of these documents, though, to support that. I'd love to see that in some of our guidelines or task force recommendations to do that, because it's a giant pinch point for all of us, and no one knows what the hell to do.
Now, the thing that you're probably going to next is these multi-cancer detection tests, these blood-based biomarkers. By the way, these biomarkers aren't specific for colon cancer. Sure, they're, but P53 and is like in everything, right? And so the question is, yeah, sure, this is a negative test for colon cancer, but what do you do next? So we're actually working, we, meaning CISNET, looking at these multiple cancers, lung, breast, prostate, colon, gastric, esophageal, trying to understand, what, if you combine these things, what are the potential effects, but also potential downsides? I mean, you end up having to do like a whole body biopsy. I mean, not just PET scanning, but what do you do with a blood test that's a multi-cancer detection? Have you guys seen this? Like 60 cancers?
Yeah.
In a blood test, they're like commercially available. How do you evaluate that?
You then go get the whole body MRI. That's what you get, which is now available for $2,200 in San Francisco.
And a whole body PET. The whole thing's crazy, right? And so it's quite a conundrum. And the technology is way ahead of our science. Does that make sense? The technology to detect these is way ahead of what we know what to do with them. And if you look at half of the cancers that they can detect are like completely uncurable, right? Especially at the stage they detect them, like pancreatic cancer. I mean, sure, you got pancreas, like, well, should have had a fishing pole and a six-pack, right? That's my therapy. And so the issues are, we're going to get into a huge conundrum with these multi-cancer early detection tests because they're so easy to get, because there's money driving this stuff. First of all, is Grail sponsoring this? No.
One of them. There's.
No. Is Grail here?
No, they're not.
Okay, good.
No, I don't believe.
So the bottom line is that what's driving this is basically it's private investment. It's Grail really, and it's amazing what they do. But I don't know what to do with the positive test because so much of this will determine on, and its potential. It's like, well, they found a little microscopic piece of something. Where did it come from? And how far to go? And so we're
struggling with a positive Cologuard. Imagine, right? I mean, it's that on steroids, right?
It's Cologuard, at least it's somewhere in the GI tract. Now we also biliary tract disease, because anything that ends up in the stool, right? So bile duct cancers, pancreatic cancers, esophageal cancer, gastric. They've looked at a bunch of these things. The only thing that looked interesting was gastric cancer, especially among people who are at higher risk, meaning a prior history of H. pylori or being born in a country endemic with gastric cancer. But boy, I don't know what to do with the rest of these multi-cancer early detection tests.
And on that conundrum, I'm gonna leave you all for a little bit of a break. Let me just foreshadow where we're going after this. Thank you all, of course, for spending your morning with us. Thank you, our three speakers, for being here this morning. We're now gonna have a 30-minute break, 11 to 11:30. There's a whole lot of wonderful sponsors next door. Please go see them. They make this in part possible. So thank you for that. Then we're gonna come back and learn a little bit about Barrett's and pancreatic cysts. Then we're gonna have, by the way, a noon sponsored lecture on Stelara by Charles Randall, who's here somewhere and is a friend and a really good speaker. So we're going to feed you and you can listen to more stuff over lunch. I just want to highlight at 4:30, we got an open bar for you. Thank you, Salix, I believe, right? We're going to have a social hour in G.I. Jane's at 4:30 down here with, did I mention open bar? It's going to be an open bar. So you all come back. We will see you now at 11:30, John. Everybody, thank you for coming.
And hi, everyone. Thank you for joining us and spending this weekend with us in Monterey. I'm Christina Cho, a gastroenterologist at Highland Hospital, part of Alameda Health System. And I'm very excited to introduce Dr. Nazia Hassan, our next speaker. So Dr. Hassan is a complex therapeutic endoscopist at California Pacific Medical Center and an associate professor of medicine at UCSF. She went to medical school at Georgetown, did her GI fellowship at NYU, and then her advanced endoscopy at Beth Israel Deaconess Medical Center. Her clinical and research interests include pancreaticobiliary oncology, radiation safety in endoscopy, and reducing the gender bias in advanced endoscopy. She has authored several publications and spoken nationally on these topics, including the most recent national guidelines on radiation safety. She is currently the Director of Pancreaticobiliary Endoscopy at CPMC, where she is the principal investigator in multiple clinical trials on chemoablation of pancreatic cysts, and also the use of radiofrequency ablation in cholangiocarcinoma and pancreatic cancer. She will be giving us a talk on novel applications of endoscopic RFA beyond Barrett's. Please welcome Dr. Nazia Hassan.
Thanks so much, Christina, for that nice introduction. Good morning. We're almost there. We're almost to lunch. Thank you to the board members for the invitation to speak with you today. I'd like to start off my talk by declaring that ChatGPT has completely failed me. So I was looking, I searched for, give me a slam dunk joke for a medical talk. And the best it could provide was this. Why do doctors carry red pens all the time? Well, in case they need to draw blood. Don't laugh at that. It's awful. I was so disappointed at the jokes it was giving me, but luckily it remained pretty pleasant despite my harsh criticism of the jokes. So anyway, hopefully my talk is better than that joke. Here are my disclosures. I did an educational course for advanced endoscopy fellows with Boston Scientific. So here's our roadmap. So we know that RFA technology has been around for a very long time through multiple modalities, including percutaneous, surgical, and of course, endoscopic approaches. This talk will really focus on the newer indications that have emerged more recently through luminal and extraluminal applications. So most of the novel applications I'm going to be talking about are really deeply seated in GI oncology, and it's helpful to think about the overall role of endoscopy in GI cancer treatment. We've made a ton of progress in terms of early disease through advances in early resection, as well as progress in advanced disease and palliation with luminal stenting and gastroenterostomies. But when it comes to locally advanced diseases, there's really been a huge paradigm shift from radical surgery to more organ preservation and the use of neoadjuvant therapy and then resection. So I think there's a real room for growth here in terms of endoscopic therapy for locally advanced disease, and perhaps ablation fits into this category. So no matter what modality we're using, RFA all sort of acts the same way. We use some kind of probe or needle or a balloon or device to generate heat and kill off the cells of the mucosal lining or our target. And that really causes coagulative necrosis. So once the cells die, it generates sort of a layer of char. And this char is what imparts resistance to further passage of current due to the concept of impedance. And this is how we really both limit and predict the depth of treatment. So here are the various ablation devices that we have. The ones that you're probably most familiar with are all in the left top corner. So those are our endoluminal devices. We have balloons, we have over-the-scope ablation catheters, as well as through-the-scope catheters. The bottom middle is a more novel biliary probe. So there's two different kinds, but they all sort of act the same way. There's thermally active components that are in the silver, and you put these over a wire into the bile duct, and it generates heat, just like the ablation devices that we use for Barrett's. The last one in the corner is an EUS guided needle. So the tip of that needle is thermally active, and there's different needle lengths that provide different zones of ablation. So RFA has been validated for pre-malignant conditions like Barrett's with dysplasia since the early 90s, and we know this is highly effective and durable. But it's also been shown to achieve mucosal ablation in several types of benign hemorrhagic diseases as well, including GAVE, as well as radiation proctitis. Although we traditionally really rely on argon plasma coagulation, meta-analysis studies have shown that both GAVE as well as radiation proctitis, you can get a better overall, RFA is more superior in terms of getting a clinical and endoscopic response, and with requiring fewer treatment sessions. So this is something that we can really consider. What's exciting about the more novel uses of RFA is the hope of sort of improving the management of patients who don't have many options at the present time. And ampullary adenomas is sort of a great example of this. Traditionally, we treat ampullary adenomas with ampulectomy, and it used to be that if there was any kind of intraductal extension of that adenoma into the bile duct or pancreatic duct, we would usually involve our surgical colleagues and send those patients for a Whipple. But we've really been able to, with RFA, we've really been able to push the limits of endoscopic therapy and do ablation of the ducts as well. That has allowed us to keep it under the endoscopic treatment and avoid surgery for these patients. Similarly, the ASGE guidelines on management of malignant biliary strictures has also suggested the use of RFA for salvage treatment for occluded metal stents, particularly for uncovered stents that we use in cholangiocarcinoma. And then lastly, this is what we're going to be diving into, is palliation in unresectable cholangiocarcinoma. So it's always helpful to have a real case to illustrate what we're talking about. This is a real patient of mine. She's a 65-year-old, otherwise healthy female. She initially presented with painless jaundice and elevated liver enzymes. She underwent an MRI that showed this filling defect suggestive of a hilar mass at the biliary hilum extending into the right intrahepatic duct and causing bilateral ductal dilation. She underwent an EUS with us and was found to have a lymph node at the celiac axis that was suspicious. An on-site pathology exam for my biopsy was suggestive of malignancy. So generally, how we manage cholangiocarcinoma patients is, well, when we do the ERCP, we'll do a mapping cholangioscopy with intraductal biopsies if the patient's going to be a surgical candidate, to help our surgeons sort of plan for surgery. In this situation, given the fact that we already have evidence of metastatic disease, we decided to just proceed with a standard ERCP. So this is where a cholangiogram looks like, very much reflective of what the MRCP images showed as well. So we did standard brushings and fluoroscopic guided biopsies and put bilateral stents in. So her biopsies came back confirming cholangiocarcinoma. She was presented to our tumor board, and there was a multidisciplinary consensus that this was in fact unresectable, and the plan was for chemoimmunotherapy and a routine stent exchange at 3 months. So when we talk about cholangiocarcinoma, this really constitutes a diverse group of malignancies, all the way up into the liver to all the way down to the ampulla. And the most common type here is this perihilar group. And this is a area of very high traffic, right? So you have your biliary tree, your portal vein, and your hepatic arteries all coming together. This makes this subtype of tumor really difficult to treat, with the worst prognosis, as well as where the biggest gap in our literature sort of exists for these patients. When we talk about outcomes, unfortunately with cholangiocarcinoma, we know that it really presents at an advanced stage and compromises therapeutic options. The 5-year survival rate is really dismal at 10%, and less than 20% of these patients are really ever going to be surgical candidates. For the few subset patients that are candidates, they may go to transplant or get resection. In terms of systemic therapy, this has really been evolving quite a bit in the last decade with the introduction of immunotherapy and checkpoint inhibitors. And then we know that local regional IR therapies are a really important part of our toolbox as well. The thing is, what ends up limiting the life of these patients is most often cholangitis, hepatic failure, really driven by biliary obstruction. So the role of endoscopy has been to really provide effective biliary drainage, keep these patients out of the hospital and on their chemotherapy. And we'll see how maybe endobiliary ablative therapies can help us do that. So on this slide, maybe this is the most important slide of my talk. The top bars are median survival in cholangiocarcinoma, and the bottom is stent patency. So we can see that with best supportive care, these patients are getting about 3 months survival. With local and systemic therapy, that can extend anywhere from 12 to 14 months. Currently, the stents that we have available to us for biliary decompression are plastic and metal stents. They provide a patency of about 3 to 8 months, depending on what we're using. But the stent failure rates and cholangitis rates in plastic stents, which is what we primarily use, is so high. And the numbers and outcomes in metal stents is better, but certainly not zero. So we see this large gap in what we currently provide and what our standard of care therapy is, and where we need to be. And so the argument here is perhaps ablative therapy can help us close this gap a little bit more. So coming back to our case, she comes back for a routine stent exchange and gets 3 plastic stents this time to drain the right posterior ducts as well. Unfortunately, 2 months later, she comes back in with cholangitis and progression of disease. We do a repeat ERCP with stent exchange, and then she's really brought back to our tumor board for discussion for the potential role of RFA in this case. So we have compelling evidence based on recent meta-analysis that both endobiliary interventions, both RFA and photodynamic therapy, well, I'll just bring up quickly, can improve outcomes. The most robust data is really in the stent patency group, but we've also seen improvement in survival. Improving stent patency can really improve the quality of life in these patients in major ways, including increasing the intervals between ERCPs, reducing cholangitis episodes, and then also allowing us to manage those occluded, uncovered metal stents. The improvement in survival, it's unclear if this is independent of stent patency, but we're not sure if it enhances chemotherapy response or if the more exciting suggestion is that there's local necrosis, tumor necrosis that enhances a immunogenic response towards tumor suppression directly. There are not many cases in the pancreatic biliary world where we're treating tumor directly, so this is a particularly exciting sort of concept for us. So coming back to our patient, she consented to undergo RFA. So here we have, this is just a little short video. The left side is our cholangioscopy, or excuse me, our fluoroscopy images, and the right side is the interductal cholangioscopy pictures, and we'll see if this video goes. Yeah, okay. So usually we'll routinely do cholangioscopy pre and post RFA treatment. Here you can see the stricture and tumor all the way up into the right intrahepatic ducts. And then we introduce the RFA probe. You can see the 2 radio-opaque markers. We start proximally and treat in an overlapping fashion. And it's basically 90 seconds of treatment and 30 seconds of cool-off. And after we've treated the entire segment and stricture, we usually follow that with an extraction balloon so we can extract all the coagulum and necrosis out. And then we'll go back in with cholangioscopy to see the treatment response and sort of see how much more room we have to maximize our stenting. So this is the post-ablation cholangioscopy picture here. We're in the right intrahepatic duct. You can see how much that's really opened up. And what we're looking for is this circumferential sort of char that we want to see. And you can imagine doing this, particularly in repeated fashion, how much more we can get in terms of increasing our stent calibers as well as increasing the number of stents we can place. So after this cholangioscopy, basically we just replaced these 3 stents and she drained very nicely. Okay, so just to review a little bit of the literature behind biliary RFA. So this is the first meta-analysis that was presented in 2018. This was 500 patients, very heterogeneous group. It included cholangiocarcinoma mostly, but also included pancreatic cancer patients. Primary outcome was stent patency and secondary outcome was survival. On the left is patency, right is survival. And we're seeing with just 1 RFA session, there's a benefit in the order of 50 days for stent patency, in the order of 37 days in terms of stent survival in this group. Again, very heterogeneous group. RFA was only performed once and chemotherapy was not given to the patients who underwent RFA. So the benefit is probably subdued here, but that was our initial look at what RFA could potentially do for us. The second study is a multi-center randomized control study. This is really focusing on cholangiocarcinoma patients. Here, they provided 2 sessions of RFA 3 months apart. It was a negative stent patency study, but if we look at the survival in the order of 5 months increase in the treatment group compared to the control group. Again, repeated RFAs, none of the RFA patients were on chemotherapy in this group either. Lastly, this is a meta-analysis of only randomized control studies. The argument up to this point, and this was just published this year, the argument up to this point is most of our data was observational and retrospective. So this looked at 6 randomized control studies that looked at RFA, biliary stent and RFA in patients that were also receiving chemotherapy, and we saw both a pooled mean difference benefit of 79 days for patency and 85 days for survival. So that data has been sort of convincing that must be some role of RFA, although there are multiple studies ongoing right now to figure out which patient population is really going to be benefiting from this and how do we create the treatment protocols. As proceduralists, complications really keep us up at night. And so particularly in this very vulnerable patient population nearing the end of their life, when we're looking at new technologies, we really have to look at the potential harms here. So this is from the initial meta-analysis study, looking at the RFA stent versus just stent alone. And we see for cholangitis, cholecystitis, pancreatitis, and hemophilia, there's no significant difference. There was an increase in abdominal pain, post-procedural pain in the RFA group. So I will counsel my patients towards this when I offer RFA. Most recently last year, it was also presented that perhaps concomitant radiation therapy might increase the adverse events of RFA. So this is something to consider when we are thinking about what patient populations we want to offer this to. So in terms of her case follow-up, she gets a repeat ERCP in 3 months with a second RFA session. And now she's been at intervals about 4 months and with second-line chemotherapy, and she's doing pretty well at 17 months post-diagnosis. So I'll take the last few minutes to kind of go over the EUS guided applications of RFA. This is really new data coming up based really on research protocols aside from a few patient populations. So we'll be focusing on the pancreatic lesions, but there's also extra pancreatic applications that are currently being trialed that have some exciting results coming out. So let's talk about solid and mucinous tumors. So I'm sure Dr. Mall will go through a lot of this in pancreatic cyst talk as well, but we know that pancreatic cancer also has a very dismal prognosis. The 5-year survival rates are about 13%, and this is only increasing. So by the year 2030, it's projected to be the second leading cause of death behind only lung and lung cancer. In contrast to this is facing this sort of epidemic of incidental pancreatic lesions that we're having with the ubiquitous use of imaging. So the incidence of pancreatic cysts has been increasing. There are some reports suggesting that patients over the age of 70 have up to a 40% incidence of pancreatic cysts. Similarly, in pancreatic neuroendocrine tumors, the incidence has increased 4 to 6-fold because of the frequent use of imaging as well. So what do we do with all these incidental findings? And we're sort of stuck here because we're currently offer surveillance, but as the incidence increases, we see that surveillance isn't always the best way to go, and for a few reasons. Regular MRIs can be onerous for patients. Radiation exposure with CT is not inconsequential. There are sedation risks that come with EUS. It can be expensive in terms of the cost of the larger healthcare system, and it's non-therapeutic. Surgery remains the main standard of therapy in terms of the gold standard of therapy in terms of pancreatic cancer, but it also comes with very high morbidity and mortality. So what do we do with these high-risk lesions that are not cancer, but that we're sort of stuck surveying? So there's a void here, perhaps, of EUS-guided therapy that we can provide. So there's multiple ablation strategies that have been tested and used. I'll just mention, and perhaps in the Q&A, we can talk a little bit more about chemoablation. That's really showing some promise in terms of mucinous pancreatic cysts. But here we'll really focus on the radiofrequency ablation. Some things to consider from the technical standpoint is the anatomic location of these lesions. We want to make sure we have a nice safety margins between our ducts and vascular structures. If there's any cystic component to a lesion, we want to aspirate that cyst as much as possible to reduce the risk of infection. And then, as I mentioned, the needle has different sizes, so it can produce different ablation zones. This is a quick video of an EUS ablation from one of my former colleagues at NYU. And as you can see, you can see a really nice burn. This is a case of a pancreatic cancer patient who was not a surgical candidate. And so this was really the only option, and they ended up doing fairly well. And this is what it looks like technically on a post-ablation, just sort of a hyperechoic enhancement of the tumor. So if you look at the data for pancreatic cyst, if you look at the complete response column, it doesn't do so well for simple cysts. This is where chemoablation will make much more progress, as we'll see the next few years. But for complex cysts or cysts with nodules, the response rate is up to 70%. When we compare RFA versus surgery for functional neuroendocrine tumors, this is a randomized retrospective multi-center study from Italy looking at these two different groups. So these are patients with insulinomas that either got EUS RFA or they got surgery at high volume centers. And if you look at the outcomes, the EUS RFA group particularly had 0 severe adverse events compared to the surgery group, and the efficacy was very similar. The relapse rate was a little bit higher, requiring perhaps a second RFA session, but otherwise RFA seems to really win out between the two groups. This is really early data looking at safety for pancreatic adenocarcinoma. This was a systematic review looking at locally advanced disease in 120 patients. And most of the adverse events, the adverse event rate was 13%. Most of them were fairly minor. There is a reduction in size, but a questionable survival benefit. Again, this is a very small population of patients, but has sort of proven that it's safe and feasible. So further studies are necessary. This is a journal proof, hasn't been published yet, but this was a group that did EUS RFA for 3 patients with resectable pancreatic cancer that were receiving neoadjuvant chemotherapy. All 3 patients were treated and tolerated the treatment and underwent surgery with no adverse events. This was really a feasibility study, but kind of shows you what's to come in terms of further trials for adding to the locally advanced pancreatic cancer group and offering neoadjuvant therapy. As I mentioned, most of the adverse events that we've seen in EUS RFA have been minor, but infected necrosis and perforation is certainly a concern. Pre-medications and technical precautions are something that can help reduce this even further. So in summary, this is sort of all of the currently established and emerging roles. And the darker the text, the more established the role, really seeing endobiliary role come to fruition. And then in terms of neuroendocrine tumor and pancreatic cysts, I think we're going to see a lot more data come out. And in the future, I think extrapancreatic lesions are not off the table. Thank you so much.
Thank you, Dr. Hassan, for that wonderful talk. Now I'm excited to introduce Dr. Jean Ma. Dr. Jean Ma is a full-time gastroenterologist at Kaiser San Jose. He majored in biological sciences at Stanford University and continued his medical education there too. After completing his internal medicine residency at Stanford University and his gastroenterology and advanced endoscopy fellowship at the University of Pennsylvania, he returned back to the Bay Area and joined Kaiser Permanente in 2018. He serves as the director of endoscopy at Kaiser San Jose Medical Center and is the associate regional lead for interventional endoscopy for the Permanente Medical Group. He will give us a talk on pancreas, cystic lesions, and making it simple for us. Please welcome Dr. Ma.
Hi, excuse me, getting over a little bit of a URI. Thank you so much for the invitation to speak with you. It's a big honor and talking about a really expansive topic here, pancreatic cyst. I had a lot of different directions that I could go. And so if there's any part of this that you had wished that I had spoken about, I'm happy to talk about it more after the session as well. Love talking about pancreatic cyst. These are my disclosures. So as Dr. Hassan mentioned, pancreatic cyst detection has been rising, and I think we're all feeling that. And it's often attributed to the increasing utilization of cross-sectional imaging. One particular study, and there's many studies that have looked at this, but one of the larger studies that looked at this found that with increasing age, you have an increasing prevalence. So going from 50s to 60s to 70s, you go from 7%, 20% to 42%. And so that's a lot of people who are getting diagnosed with pancreatic cysts. The clinical management, once you find a pancreatic cyst, revolves around the determination of the likelihood that the cyst or cysts harbor advanced neoplasia, and also the likelihood that those cysts may develop advanced neoplasia in the future. These cysts can represent a whole multitude of different things: pseudocysts, serous cystadenomas, IPMNs, MCNs, SPNs, neuroendocrine tumors that have a cystic component to them, or other more rare cysts, such as lymphoepithelial cysts. So I'm just going to go over each of these in a little bit more detail. Pseudocysts, we're all familiar with. These typically have an antecedent history of pancreatitis. On imaging, depending on the lesion, can have fluid plus or minus necrosis. After some time, they have a well-defined wall. The fluid analysis shows that typically the fluid's brown, low CEA, high amylase. This is just a representative photo of a pseudocyst, very large here. You can see a nice defined wall. This one's in the tail of the pancreas, as you can kind of imagine with this particular size can be causing symptoms. This is just a photo of a lumen-imposing metal stent that was placed for a purpose of a cyst gastrostomy, allowing for drainage of a symptomatic pseudocyst. And so that's really kind of revolutionized our management of these cysts that require any sort of intervention, whether it be because they're causing symptoms or if they're infected, for example. Serous cystadenomas, typically in women, typically a bit older. Many of them have a microcystic or honeycomb appearance to them. On imaging, if they have a central scar, that's oftentimes pathognomonic. These have a low CEA, low amylase. This is a representative image with the straight arrows pointing at the honeycomb appearance that can be seen, the curved arrow showing a central scar. This is the appearance that you can see on endoscopic ultrasound, where you may be able to make out the kind of honeycomb nature of this cyst, which is pathognomonic. It really kind of hits home the diagnosis such that you may not even need to sample it. IPMNs I'll talk about in more detail moving forward, but I'll just briefly go over here. Similar prevalence in men versus women, typically older. There's different anatomic classifications: branch duct, main duct, mixed type, have a high CEA, low amylase in most cases. And again, I'll go over this in more detail. MCNs, typically women, typically in the 5th to 6th decade, mostly in the body, mostly tail, I should say. And then usually unilocular. One of the kind of buzzwords that you might see on your boards is ovarian stroma on the path. If there are peripheral calcifications, there's a concern for malignancy. And these also have a high CEA, variable amylase. This is just a CT image of an MCN, a large MCN in the tail of the pancreas. SPNs, typically, mostly in women, usually younger women in their 20s, unilocular, usually, and oftentimes have a solid hemorrhagic component, oftentimes very large. So kind of a typical presentation for an SPN would be a very young woman who's presenting with abdominal pain, gets cross-sectional imaging, is seen to have kind of this very large lesion in their pancreas, usually heterogeneous with some hemorrhagic component. And you can kind of see that here on CT. You can kind of make out that it's pretty heterogeneous, not very dissimilar from some of the other images that we've seen for the other cysts. Cystic neuroendocrine tumors, usually non-functional, no particular predilection to men versus women, can be solid, but then also have a cystic component to it. These are typically hypervascular, hyperenhancing on cross-sectional imaging. And they have a low CEA, low amylase usually. You can see here this hypervascular lesion on CT is a cystic neuroendocrine tumor. So I put these in an intentional order. Anytime we see any particular lesion, whether it be the pancreas or anywhere else, one of the first things that kind of jumps to mind is, what our level of concern is for these lesions. So more specifically, this is kind of concern with regards to any malignant potential. So the ones highlighted in green here, pseudocyst, serous cystadenoma, really have no significant risk for malignancy or malignant transformation. And so typically these are the lower risk lesions. Doesn't mean that you don't need to intervene upon them, but at least from that malignant standpoint, lower risk at the bottom of the totem pole. IPMNs of the branch duct variety certainly have malignant potential, and do warrant surveillance, but the vast majority of these don't cause any issues in a patient's lifetime. The ones in red typically require some intervention, whether that be referral to surgery for consideration, or even just a strict recommendation for surgery if they are surgical candidates. But the ones highlighted in red here, the IPMNs of the main duct variety, mixed type, MCNs, SPNs, cystic neuroendocrine tumors do require some intervention if the patient is eligible for any sort of treatment. So as promised, wanted to talk a little bit more about IPMNs. They come in a branch duct variety, whether it be a single branch duct IPMN or multifocal, diffuse main duct, segmental main duct, or mixed type involving both branch duct and also the main duct. Diagnostic testing includes cross-sectional imaging with CT scans with a pancreatic protocol. Here you see a diffuse or a main duct IPMN on CT. MRI, MRCP can also be useful. In this particular image, you're seeing a branch duct, a cluster of branch duct IPMNs in the tail. Endoscopic ultrasound, also helpful. On the upper image, you see an IPMN with the arrow pointing to the pancreas duct connection. And in the lower image is a main duct IPMN with some frond-like projections. EUS also allows for sampling, particularly if you see a solid component mural nodule. Endoscopic is something, we're not really doing endoscopies to evaluate IPMNs, but that's why there's an asterisk there. If you see this, classic fisheye sign, that's the pathognomonic for a main duct IPMN. So in terms of pancreatic cyst management guidelines, these have kind of evolved over the years. So in 2006, the International Consensus Guidelines were published. These were known as the Sendai Guidelines at the time, published for the management of mucinous cysts. These were then updated in 2012, known as the Fukuoka Guidelines. This year, actually, there was a further update, which I wasn't able to include before kind of finalizing these slides, but known as the Kyoto Guidelines. So the Fukuoka Guidelines, now known as the Kyoto Guidelines. In 2015, the AGA published guidelines for management of incidental pancreatic cysts. 2018, ACG had their guidelines for the management of incidental pancreatic cysts. And again, this year, the Kyoto Guidelines. So I'm not going to go over, the nitty-gritty of each of these guidelines, but one of the things that I wanted to kind of mention is that these guidelines have, they use different terms for for kind of similar things that they're speaking to. So one of the ways that I kind of think about these guidelines is that they speak about what I call high-risk features that would warrant recommendation for a surgical resection, and then some worrisome features that would lead to recommendation for further evaluation or surveillance. Evaluation usually meaning endoscopic ultrasound. As I mentioned, these are quite variable across the guidelines with regards to what they would define as a high risk or a worrisome feature, and also what they would recommend as the next step with each of these features. You can see some common themes though. For example, for high risk, you kind of see that high risk features oftentimes involve a solid component, some degree of pancreatic duct dilation, obstructive jaundice certainly, and worrisome features are much more, there are many more of them, and again, they have some common themes to it, but yeah, each of them is quite different from that standpoint. This kind of speaks to the fact that despite how common this issue is, there's a relative lack of evidence to kind of guide our management of these cysts. And I'll get to one of the reasons why shortly. So not going to go through each of these little branches, but these are the Fukuoka guidelines. Again, Kyoto guidelines updated now. ACG guidelines here, AGA guidelines. And one of the things I wanted to highlight about the AGA guidelines is that, which is something that really kind of sparked a lot of discussion with regards to pancreatic cysts, is that they allowed for stopping surveillance, which was kind of a concept that I think that was a good one to discuss, because I think that all of us have had our patients who have undergone surveillance after surveillance after surveillance with their IPMNs remaining, the same size, or suspected IPMNs, or, known IPMNs. And so AGA guidelines kind of discussed that after 5 years, if there was no development of any concerning features, that allowed for a cessation of surveillance. I definitely think that there's a role for that. The updated international consensus guidelines, the Kyoto guidelines, also offer this recommendation for cysts mucinous cysts that kind of don't have any change in their features over a period of time. So I think that that's something that's important. And actually, one thing I wanted to get to about this is also that the way that I kind of look at these guidelines is that and which one to use is I oftentimes use the AGA guidelines more for the patients that have that philosophy of care of less is more, or if they're just of the appropriate patient type that perhaps they say recommend to me whatever you feel is right for me. And so if, for a very for a patient with a lot of comorbidities, elderly, or, you feel that they have that kind of less is more kind of mentality to them, I tend to kind of gravitate more towards the AGA guidelines for them, because they kind of allow for, it's a little bit more liberal in allowing you to stop surveillance in the appropriate population. So in terms of the future of pancreatic cyst management, as I alluded to, the pancreatic cyst guidelines are not perfect. They lead to a whole host of false positives, which results in potentially avoidable resections. They also do not capture all patients with invasive cancer nor high-grade dysplasia. There's a pressing need for diagnostic tools to accurately diagnose advanced neoplasia and also determine the likelihood that these cysts can develop advanced neoplasia. Cyst management requires thoughtful discussion with your patient regarding the risk and benefit in the context of their comorbidities, given the lack of definitive answers in many of these cases. I would say in the vast majority of these cases. There are a lot of different tests that have kind of come along the way with regards to pancreatic cysts. Some that come to mind include, for example, pancreatic cyst glucose measurements. We have our CA amylase, Pancreagen, previously I believe known as RedPath, was, or actually still is, something that is utilized. One thing that has gained a little bit more traction recently is pancreatic cyst fluid next-gen sequencing. There's one in particular that has gained quite a bit of traction in the past couple of years, and that's PancreaSeq, which is at the time it was a study of a 22-gene NGS panel. Now I believe it's in the one that's offered as a 74-gene panel. It had a very good sensitivity specificity for mucinous cyst, and it also, in addition to defining the type of cyst, gives a pretty good evaluation of low risk versus high risk, and kind of gives you that information as well as kind of the reasoning behind it with regards to the different DNA mutations, loss of heterozygosity, and quantity of DNA. They're able to kind of provide you with a little bit more granularity with regards to the risk for these cysts. The caveat to all of this pancreatic cyst research, which is the reason why we have kind of this dearth of evidence for management of pancreatic cysts, is that you're looking for advanced neoplasia or the development of it. So you really need to have surgical pathology, which means that the patients need to have surgery, or they need to have a very long-term follow-up for those who don't have surgery. And so that's the challenge, is that many of these studies have that, or all of these studies have that issue. And so the results have to be taken with a huge grain of salt. So just in terms of my overall approach when a pancreatic comes in with a pancreatic cyst, most of these patients, as I'm sure that you've seen in your own practice, they come very anxious about their pancreatic cyst. They hear pancreas. Anyone hears about something wrong with any organ in their body, they're worried about cancer. And one thing that I just say right off the bat, unless obviously there is a concerning feature about that cyst, mural nodule or, significant weight loss or something like that, or obstructive jaundice. If this is just your garden variety pancreatic cyst, one of the first things I start off with is I just mentioned to these folks, a lot of people on their same boat are in the same boat as you. If they're in that 70s range, which many of them are, I mentioned to them that in your age range, about 40% of folks in your age range have a pancreas cyst. So it's very common. And as you can imagine, not 40% of people develops pancreas cancer. It's still a very rare occurrence, even when you have a pancreas cyst. And so that generally helps to kind of diffuse the anxiety quite a bit. At that point, you assess their clinical history, look at the imaging for clues on the type of cyst that this may represent. You're assessing for any high-risk features, like a solid component or pancreatic duct dilation. And then you make judicious use of the guidelines that you have. Again, they're not perfect, but they are helpful in guiding you. And they are very nice in the sense that there's not really any holes with regards to them. They kind of tell you what they recommend with regards to what the next steps are. So just in summary, just some high yield points. Serous cyst adenomas typically are microcystic, honeycomb, and can have a pathognomonic central scar. Serous cyst adenomas require no surveillance or intervention. IPMNs and MCNs have a high cyst fluid CEA level. IPMN high-risk features include solid component and pancreatic duct dilation. MCNs usually are large, are found in women in the body and tail, and they should be resected. We have guidelines available to us for decision-making, for assistance in our decision-making process. There's hopefully a lot of promising research and promising interventional tools that we have coming down the pike that Dr. Hassan alluded to as well. And hopefully cyst management becomes simpler and simpler moving forward. And one thing that one of my mentors said to me all the time is that if you are the only person standing in the way between folks and food, you better get out of the way before they run you over. So with that, I'd like to thank you again for your time.
Well, thank you for the talk. Both of the talks were awesome. Does anyone have any questions or anything? There's 2 microphones on the left if you could come up and ask questions. I also know we're running a little bit late, and I know everyone's hungry because it's been a full day. But if not, I was hoping, Dr. Hassan, can you just briefly go over, I think you mentioned it briefly in your talk, but about the pancreatic cyst, and you mentioned RFA, but what the other treatment modalities and how we would incorporate it?
Sure. I can speak to it, or Dr. Mack can speak to it as well. But there's a trial called the CHARM trial that was published about almost 3 years ago now, out of Penn State that suggested chemoablation. So traditionally, the ablation method that's been used or trialed for pancreatic cysts is alcohol ablation, and it hasn't done so well. The adverse events or the rate was just so high. But chemoablation looks very, very promising, and it's where we basically, if you have a unilocular or a cyst with less than 3 septations, we aspirate. It's a high-risk cyst with no malignancy, right? And it's a mucinous cyst. You've already confirmed that with your diagnostic testing. And the patient really wants therapy, and because they're not a surgical candidate or they don't want surveillance forever, whatever it is, we aspirate that cyst completely and then reintroduce a chemo cocktail of gemcitabine and paclitaxel into that cyst to reconstitute that cyst into the same exact size that it was. And the response rates have been pretty impressive, in the order of 60 to 70%. CHARM-2, which is a larger multi-center trial to see if these response rates are durable, is going to be out in the next year or so. But we also have a trial that's starting at CPMC if you have any patients that would like to enroll. But it's sort of an option. As I was mentioning, it fills that little gap between surveillance and surgery where we may see some promising results. And the adverse event rate for the chemoablation was 0 in that first trial.
Okay. Cool, thank you. What about for Dr. Ma? I know you mentioned that for some of your patients, depending on their personality and also and things that you might use the AGA guidelines, but out of all these guidelines, is there one you prefer or maybe one that you would recommend to our trainees to go over?
Yeah, definitely. So I don't necessarily have a preference towards any particular guideline. Well, we all have our preferences, but I'd say that definitely the AGA guidelines are kind of the simplest. You could even just tell just visually that the arms that you're going through are pretty simple, and they're looking at very few features. I really very much reserve those for the patients that I kind of come in with this pre-appointment kind of concept that I'm likely going to, even if they may not be a less is more type of philosophy, I'm probably going to recommend that to them. One of the things that we always preach is, do no harm. And so I really don't want to be, for example, recommending endoscopic ultrasound to a very elderly patient who is very unlikely to derive any benefit from any intervention that we do, even though endoscopic ultrasound is incredibly safe. If anything, it's actually probably the anesthesia associated with it that has a higher risk factor for those patients. But I'd say that in general, I kind of just tend to gravitate more towards the international consensus guidelines with now the Kyoto guidelines. But realistically, I think that the best guideline is the one that you are familiar with and that you use consistently. I think that's the key here because, I think the key is to follow one of the guidelines consistently and have that consistency because, the last thing you want to do is just kind of reflexively, for example, just refer everyone for endoscopic ultrasound. I think that would be the thing that I would definitely not advocate for.
Okay. Thank you.